waiting to get connected. We are going to start a marathon session on pediatrics NEET PG pediatrics session right now. Let me check whether it is getting connected to my YouTube session. Waiting for the connection to happen so that I can start my session with confidence. Hello. Yeah, it's ready. Shall we start? Okay, right. To start with, so I'm not going to waste much of your time, neither my time. Good morning. Okay, Tika, Nirisha, Ram. Okay, good morning for all of you. I hope that you had your tea or coffee in the morning. So let me start my session right now. Okay, shall I? Right. Hi, Dana. Good morning. Right. So when you have this kind of lesion, what will be the first possible diagnosis you can have? The first possible diagnosis you can have when you see this kind of this. What is this? What is the diagnosis? We don't have much time. What is this and what is the diagnosis? Okay. What is this? So what is this? There are many new things also along with the old one. Right. So what is this actually? Scrub typhus. Very good. Right. So, right. So this is scrub typhus when you have fever of more than 7 days duration along with hepatosplenomegaly or acute renal failure, acute myocarditis, acute hepatitis or acute meningoencephalitis. Apart from TB, apart from typhoid, in our country, scrub typhus caused by Rickettsia Sutsugamushi is becoming very common. And remember, the most pathognomonic sign is this Eschar, otherwise known as tachynoia. You need to look for it rather than ask why, because it is absolutely painless and it is non-pruritic, as a result of which the child will not say. That's why you need to search for in and around inguinal region, periumbilical region, axillary region, buttock region, as well as in and around auricular region. All skin folds should be examined. Scrub typhus is becoming very common in our population as well as in our MCQ for you. Rickettsia Sutsugamushi, and this is the place where the mite has bitten you. So this is absolutely painless and non-pruritic. Most common in India is scrub typhus caused by Rickettsia Sutsugamushi. It can also cause, as I discussed already, apart from meningoencephalitis, acute pneumonia, hepatitis, renal failure, myocarditis. It can cause gangrene because it produces vasculitis of small vessels, leading to endothelial microvasculitis. And you all know it is caused by the bite of trombiculoid mite. So what is the investigation of choice? If they give you a picture like this and if they ask you what is the investigation of choice, tell me. What is the investigation of choice? What is the drug of choice? Waiting for your answer in YouTube channel. What is the investigation of choice and what is the drug of choice? MCQ. IgM ELISA. Then is it Will-Felix test? OXK. Is it wrong or right? IgM ELISA, PCR in tissue fluid, Will-Felix test, OXK. Doxycycline is the drug of choice. Why not azithromycin? Yes, you are all correct. The diagnosis is IgM ELISA. The diagnosis is IgM ELISA. We are not doing Will-Felix test right now. With respect to 𝐂𝐿K, it is of any epidemiological importance only. But okay, but remember, IgM ELISA will be gradually replaced by PCR in tissue fluid. PCR in tissue fluid, because it is a direct test which looks your strep typhus, that is Rickettsia Sutsugamushi. Drug of choice. Drug of choice is doxycycline for 7 days. Doxycycline for 7 days. If not, azithromycin. Previously, it was azithromycin, but in the past 3 years, it has been replaced by doxycycline because of the increasing resistance to macrolides. What will be the count in scrub typhus? What will be the count in scrub typhus? Total count will be less than 4,000. There will be platelet of less than 1.5 lakhs, mild thrombocytopenia. You will have low sodium hyponatremia. You have low albumin, serum albumin less than 4 grams per deciliter. And one more important point, you can have deranged SGOT and SGPT. OTPT will be elevated. Transaminitis. So one cause for fever with the transaminitis is scrub typhus. You are well versed with that. I am going to the next one. Okay, and again, you know what is this. Let's go very fast. It was discussed in your FMGE. First 15 to 20 minutes will be some repeated topics. Then we will switch on to new topics. So what is this? You all know what is this. So what is this called as? It was discussed previously. What is this called as? So this disease is called what? And it is caused by dash virus. This virus is associated with CCC, coryza conjunctivitis. What is this? This disease is characterized by fever, coryza conjunctivitis and red maculopapular rash. Which disease is associated with this? And it is a viral infection. Starts with the red maculopapular rash in and around the periauricular region. Still you are thinking, you need to answer by that time. Yes, Ram, it is measles. And what is this called? This is called as noma. This is called as noma. This is called as noma. Noma is nothing but necrotizing fasciitis. Noma is necrotizing fasciitis occurring in children who suffered from measles, which in turn leads to severe acute malnutrition. Right. So again, some rapid fire questions. So usually, so fever over, what is the rash? So the rash usually, okay, fades over 10 days, and the rash usually leaves some brawny discoloration. One, the rash usually starts in and around periauricular area. Another questions they can ask you, what is called modified measles. Modified measles, milder form of measles, occurs in partially immune individuals. What is called hemorrhagic measles? Sometimes the rash which bleeds like a petechiae and purpura mimicking your meningococcemia, that is called hemorrhagic measles. Okay, most common complication, two most common complication. One is pneumococcal induced otitis media. The second one is Staph aureus pneumonia. And remember, there will be a reactivation of Mycobacterium tuberculosis, as we explained already. Noma is nothing but gangrene of cheek occurring in measles with severe acute malnutrition. And remember, if they survive this insult, by about adolescent period, they can present with neuroregression along with periodic complexes, seizures. What is that called as? SSPE, subacute sclerosing panencephalitis. The investigation of choice for subacute sclerosing panencephalitis is IgM anti-CSF measles antibody, right? So even for acute infection, you can choose IgM ELISA against measles antibody. Okay, remember, phase is involved in case of measles, and the treatment of choice is usually vitamin A. And people will be asking you, what is the role of vitamin A? Vitamin A not only reduces your blindness, remember, it reduces overall mortality. It was once asked in AIMS, INI-CET. So it reduces overall mortality. Don't just write it reduces the incidence of measles, it reduces overall mortality. And you all know that MMR vaccine is given at 9th month and once at 15 to 18 months, but IAP. So this is universal immunization schedule, whereas Indian Academy of Pediatrics scheduled, this is not the schedule of IAP, it is MMR at 9th month, the second MMR at 15 to 18 months, and the third MMR at 5 years. So one at 9th month, second at 15th to 18th month, the third at 5 years. The problem is our universal immunization schedule lacks mumps. Right now we have been seeing so many cases of mumps induced encephalitis, as well as we have been seeing many cases of mumps induced otitis media, mumps induced complete deafness, as a result of which the government is planning to introduce mumps vaccine along with the measles and rubella very soon, right? It doesn't mean that mumps will produce arthritis or oophoreitis in the adolescency age group. It can produce catastrophic meningoencephalitis and catastrophic permanent sensory neural deafness in children, right? Can you tell me what is the important clue for mumps and herpes simplex encephalitis? Waiting for your answer. What is the clue for mumps induced meningoencephalitis in CSF analysis? Ram, Sharon, Gayatri, Dhanalakshmi, tell me what is the clue for mumps induced meningoencephalitis? Anyone? Mumps induced meningoencephalitis. Your mumps as well as herpes virus can produce two specific conditions in CSF. What are all they? Anyone? All viral infections will be associated with the lymphocytosis, that is not an MCQ. All viral infection associated with the minimal protein elevation, that is not an MCQ. But usually bacterial meningitis are associated with the reduced sugar hypoglycemia in CSF. But only two viral infections that can produce, okay, only two viral infections can produce hypoglycemia. One is mumps, another is herpes encephalitis. So in your examination, if protein is minimally elevated, if lymphocytes are minimally elevated, but your CSF sugar is reduced a lot, if your CSF sugar alone is reduced like a bacterial meningitis, then you need to think in terms of two meningoencephalitis. One is mumps, second one is herpes simplex encephalitis. Hypoglycemia is common. Okay, next. What is this? What is this? So you all know this is, what is this? You all know this is, what is this? So this is Zika virus. Zika virus belongs to what? Apart from dengue and chikungunya, your dengue, chikungunya and Zika virus are all caused by, transmitted by Aedes aegypti. You all know that it is all caused by Aedes aegypti. So whenever a mother is affected, primary infection with respect to, I repeat, primary infection in the mother, particularly in the first trimester. Okay, particularly in the first trimester, then there can be chances for Zika virus producing microcephaly. Apart from that, it can produce Guillain-Barré syndrome, transverse myelitis and meningoencephalitis. Very good. So it belongs to flavivirus. Remember, microcephaly, one of the Zika virus has become, they have included Zika virus in TARS infection. So what is the investigation of choice in the first 7 days? The investigation of choice is, as for any other viral infection, RT-PCR in the blood. But after 7 days, because of the presence of production of antibody, then IgM capture ELISA will be the investigation of choice. First 7 days PCR in blood, next 7 days IgM ELISA. Very good. Then treatment. Treatment, we can't offer any treatment. How do you differentiate between dengue and chikungunya? All of them causes fever, headache, arthritis and conjunctivitis. How do you differentiate between these three? What is the peculiarity of a Zika virus when compared to dengue and chikungunya? Yes, the treatment is none. Apart from dengue and chikungunya, what simple clinical clue for Zika virus? The answer is okay, the rash is profound in primary infection and conjunctivitis is more profound compared to your dengue and chikungunya. Remember, only 3 to 4 diseases will cause bulbar conjunctivitis. What are all the diseases that produce bulbar conjunctivitis? 1. What are all the diseases that produce bulbar conjunctivitis? Can you tell me? One is what are all the diseases that produces bulbar conjunctivitis? One is dengue. Yes, as we discussed already. The second one is Zika. The third one is chikungunya. These are all viral infections. What is the bacterial infections that produces bulbar conjunctivitis? Waiting for your answers. What is the bacterial infection that produces bulbar conjunctivitis? Waiting for your answer. Bacterial infection that produces bulbar conjunctivitis. Fever, deranged? No, it's not Neisseria Dugu. Fever, deranged LFT, deranged RFT, close to some rice paddy fields? No. Contact rainfall is there. Modified Fain criteria. One clue let me give you. Modified Fain's criteria. I have been giving you many clues. Modified Fain's criteria. That's it. Joshi, that's it. So it is leptospirosis. It is leptospirosis. The bacterial infection that produces bulbar conjunctivitis is leptospirosis, which is very diagnostic of leptospirosis. Now you tell me what non-infectious cause that produces bulbar conjunctivitis. Non-infectious cause that produces bulbar conjunctivitis. That's very easy. An infant with a high grade fever lasting for more than 5 days, along with elevated ESR and elevated CRP, neutrophilia, hypoalbuminemia. Answer: non-infectious cause for bilateral bulbar conjunctivitis. Waiting for your answer. It's not that tough, my dear boys and girls. That's not tough. That's very easy. What happened to you? I told you the clue na. Fever lasting for more than 5 days. Infant, elevated ESR, that's it. Nitu Patak, very good. That is Kawasaki disease. So remember, in pediatrics, bulbar conjunctivitis has got only very minimal conditions as differential diagnosis. It is Kawasaki disease, leptospirosis, and viral infection that are flavivirus infections such as dengue, Zika, and chikungunya. Right? Okay. Apart from that, these things are very easy. Let's go as a spotter as early as possible so that we can switch to the next topic. So what is the first picture? Shows that the triad of 1 2 3. What is the first one? What is the answer? What is the answer for A? What is the answer for B? What is the answer for C? All of them are torch infections. Let's not waste much time in this easy one. So the first one is ear, sensory neural deafness. The second one is patent ductus arteriosus. The third one is bilateral cataract. Yes, it is congenital rubella syndrome. Then let's go to B. What is the answer for B? What is the answer for B? What is the answer for C? Nitu, you need to mention B is what, C is what. Instead of just saying Ram, toxoplasmosis and CMV, I don't think this is of great difficulty to my children. So this is diffuse cerebral calcification. This is diffuse cerebral calcification. And what is this disease? Periventricular calcification. As my children are very confident, the first one is toxoplasmosis, the second one is periventricular calcification, that is cytomegalovirus. That's it. Good. That's not. Now you tell me what is the first MCQ. So let me ask some small MCQ. Most catastrophic torch infection is what? Point number one. Most catastrophic torch infection is what? Second one is what torch infection is having good treatment facilities, what has got partial response to treatment, what has got no treatment at all. Now waiting for your answer. Which one has got catastrophe in the fetus? Which torch infection we can offer good treatment? Which torch infection we can offer partial treatment? And which torch infection we cannot offer any treatment and we need to go for abortion? Waiting for your answers. Okay, waiting for your answers. Okay, no one is answering. Catastrophe is congenital rubella syndrome. Less than 11 weeks, unless otherwise proved, the child will have all these issues. So abort. Abort. Catastrophe, no, not toxoplasmosis. Good treatment facility is available for toxoplasmosis. Good. 1 year of pyrimethamine and sulfadiazine along with the folinic acid. 1 year. Relatively good. Partial is CMV. And no treatment, as I told you, congenital rubella syndrome. Others also have got partial response to treatment. Okay. Now, so as you all know, 1 second. Napa. Napa. வச்சுக்கோ வாங்கிக்க. Okay, what is this? So apart from that, periventricular calcification, you all know cytomegalovirus, the triad of hydrocephalus, chorioretinitis, and intracerebral calcification, you know it is toxoplasmosis. Tell me, what is the maternal infection that leads to fetal infection and disease but subclinical? Can you tell me what is the answer for this one? What is the answer for this one? So this is one. So this is 2, this is 3. Which maternal infection is almost subclinical but can produce a catastrophe in the child not at birth but even after some time? Anyone? Not at birth but even after some time. Late onset sensory neural deafness, clue, late onset microcephaly. So what is this? Congenital toxoplasmosis as well as cytomegalovirus. Right. So what is this? Tell me the phase in which even when the mother is affected, the child is absolutely fine. Tell me the gestational age. Tell me the gestational age in which mother is completely affected. Gestational age beyond dash, mother is absolutely not affected. Mother is not affected. It is 16 weeks. 16 weeks. After 16 weeks, nothing is going to happen. No need for abortion even when the mother is affected for the first time. You all know patent ductus arteriosus, sensory neural deafness, and cataract is congenital rubella syndrome. What is the investigation of choice for cytomegalovirus? Waiting for your answer. What is the investigation of choice for cytomegalovirus? What is the investigation of choice for cytomegalovirus? Answer. Waiting for your answer. Cytomegalovirus is often asked question. Only in the presence of urinary PCR, yes, okay. So remember two infections which can produce again late manifestation. Apart from that, toxo is cytomegalovirus and syphilis. The child can be initially normal but later can be affected. Okay, only torch infection that produces abortion. Only torch infection that produces abortion. Yes, urinary or salivary PCR. Usually we use urinary PCR, and it is not qualitative, it is quantitative PCR, because qualitative PCR, hundreds, 200s will be normal in you and me also. It should be in lakhs. Okay. Right. So what is the only torch infection that produces abortion? It is syphilis. Treatment for toxoplasmosis, as we discussed, pyrimethamine and sulfadiazine for about a year. Treatment for this is very, very important. This is very, very important. Treatment for congenital CMV. Treatment for congenital CMV is IV ganciclovir for 6 weeks. IV ganciclovir for 6 weeks, followed by oral valganciclovir for 6 months. IV ganciclovir for 6 weeks, followed by oral ganciclovir for 6 months. So IP ganciclovir IV 6 weeks, oral valganciclovir 6 months. That is very, very important. So this is again very, very easy. What is the disease? So this is slapped cheek appearance. You all know, caused by erythema infectiosum or fifth disease, caused by Parvovirus B19. It has got peculiar propensity to affect which cell in the body. It can affect many, many regions. It can cause, okay, yeah, it is erythema infectiosum. That is not that much difficult. But my question is, it affects particularly which? Okay, instead of saying RBC, you need to say particular term. Yes, you need to say particular term. What is this? Pronormoblast. It is pronormoblast, as a result of which it produces red cell aplasia. It also produces immune thrombocytopenic purpura, aseptic meningitis, and arthropathy. Remember, apart from this, they can ask you these questions. So it can cause parvovirus increasingly being recognized as the most common cause for viral myocarditis, MCQ. Increasingly being recognized as a cause for pediatric myocarditis, Parvovirus B19, very important MCQ. And antenatal parvovirus by affecting the fetus and causes destruction of RBC, leading to Hydrops fetalis. What is the most common cause for Hydrops fetalis in what is the most common cause for Hydrops fetalis? The most common cause is 1H immune, non-immune. Immune is Rh incompatibility. Immune is Rh incompatibility. So mother positive, child mother negative, child Rh positive. Non-immune eye drops is fetal supraventricular tachycardia. So fetal supraventricular tachycardia. Apart from that, again parvovirus is increasingly being recognized to produce fetal eye drops. Right. Aplastic crisis, as you all know that aplastic crisis in underlying any hemolytic anemia, this Parvovirus B19 can produce aplastic crisis. Whether it is a G6PD or hereditary spherocytosis or thalassemia, it can cause. So what is the new thing that you can learn? The most common cause for myocarditis increasingly being recognized as due to Parvovirus B19, unexplained myocarditis. What? Second one is non-immune eye drops is SVT followed by Parvovirus B19. Treatment, nothing we can offer. Right. Okay, next. So what is this? Waiting for your answer. What is this? So what is this? Is this a streptococcal pharyngitis or something else? So is this streptococcal pharyngitis or something else? How do you say it is streptococcal and pharyngitis, and how do you say it is not? Can anyone tell me how to differentiate between streptococcal pharyngitis and infectious mononucleosis as well as diphtheria? Anyone? Yes, it is diphtheria. Membranes are there, unless otherwise you peel, it will be very difficult to identify whether it is diphtheria or not. It can be streptococcal, it can be viral, it can be diphtheria, it can be EBV. How do you say so? Numerous questions can be framed based on the presence or absence of membranous exudate. Can anyone tell me how to differentiate between these three? Because definitely one question will be asked based on the presence or absence of exudative pharyngitis in a child with throat pain. Anyone? So remember carefully, it's not that difficult. So whenever you have a case of exudative pharyngitis, very simple, either it can be group A beta hemolytic streptococci, or it can be diphtheria, or it can be Epstein-Barr virus. All three are equally important with respect to MCQs. So how to decode? Very simple. So here the child is toxic. The temperature is very high. You have tender JD node, tender jugulodigastric node. 1. What about diphtheria? The child is very toxic. Temperature is low grade fever or no fever. Tender, it is not tender, it is life threatening. What? Submandibular swelling. Bull neck, very good. Swelling, otherwise known as bull neck. EBV. Toxicity, no toxicity at all. EBV, the child will not be toxic. Temperature, very low grade fever usually. And what about note? Generalized lymphadenopathy, very important. So both the anterior triangle of neck and posterior triangle of neck will be involved. Along with that, generalized, along with that, you have splenomegaly. So when you have exudative pharyngitis, these three questions can be asked. Apart from that, one important clue for pharyngitis is viral. How do you know that it is a viral normal pharyngitis? So remember, if you have cough, if you have coryza, if you have palatal ulcer, I repeat, cough, coryza and palatal ulcer is suggestive of viral pharyngitis. There is no need for any treatment. What is the treatment for group A beta hemolytic streptococci? Yes, waiting for your answer. What is the latest management of group A beta hemolytic streptococci? Waiting for your answer. Ram, Nithik, non-purulent. Answer. What is the recent management in group A beta hemolytic streptococci? Amoxicillin for how long? And amoxicillin should be started within dash days. Amoxicillin BD, OD, TID. How many days? How fast you need to start your amoxicillin? Waiting for your answer. Ram, Nitu, Dugu. Yes. Amoxicillin, I agree. Remember, amoxicillin should be started within 9 days. If not, there are high chances for carditis. So amoxicillin should be started within 9 days. Second point, amoxicillin should be given for 10 days. Third important point, as per Nielsen, OD dose is recommended right now. It is not BD or TD. Amoxicillin OD for about 10 days, maximum of 1000 grams per day. If the child is small, 50 milligram per kilogram per night. So Amoxicillin not 8 to 10 days, but amoxicillin 10 days. It should be started within 9 days of after the onset of pharyngitis. RAM 50 milligram per kilogram per day is correct. At that 50 milligram per kilogram per day is, instead of dividing into OD or BD dose, it is once daily dose as per recent recommendation. Only once daily at night is more than sufficient. And another important MCQ. Okay, right. So you all know that whenever now right now, so when will you suspect diphtheria? Diphtheria can be suspected if the child is more toxic, but the temperature is plus or minus, along with, as you told, bull neck. Okay, now tell me, what is the most important complication of diphtheria? Name topmost complication of diphtheria and most common cause for death in diphtheria is due to what? Most common cause for death in diphtheria is due to what? MCQ. Polyneuritis, palatal palsy, airway obstruction, toxemia. Answer A, B, C, D. Myocarditis. The most common complication. Is it myocarditis? Is it descending paralysis? Is it a palatal palsy? It is airway obstruction. It is airway obstruction to the respiratory failure. Leading to respiratory failure is the most common manifestation of diphtheria. Okay. So in the first itself, they can manifest very good. Yes, Nitu, they can present with say life-threatening obstruction of the larynx, leading to death in the first week itself. That's why diphtheria has been introduced in the vaccination schedule. Previously, we didn't give diphtheria at 10 years, but at present, the universal immunization schedule has introduced small d, that is capital T small d, that is called TD vaccine at 10 years, and one more booster at 16 years, thereafter every 10 years. Right. So what is the most common complication in the second week, third week, and after that? Anyone answer? What is the most common complication in the second week, third week, and between after third week? First week is, it is usually death due to obstruction by the membranes. Whereas in the second and third week are mainly due to what? Waiting for you to answer looking at the YouTube messages. Answer please. Anyone? This is very important. Myocarditis. Let's see. Is it myocarditis? Yes. Myocarditis, arrhythmia, as well as palatal palsy. Descending paralysis is common after 3 to 6 weeks, but direct invasion of the toxin can itself produce palatal palsy, leading to nasal twang of voice and nasal regurgitation. So it doesn't mean that it has to come after third week. Okay, after 3 to 6 weeks. So second week, myocarditis and palatal palsy leading to arrhythmias, death, or leading to palatal palsy, nasal twang of voice, and regurgitation of food. Third week, as you all know, it is what? Ocular palsy. It is not palsy. Third week, it is usually ocular palsy. And another MCQ that they can ask is, what is an important MCQ they can ask with respect to diphtheria causing with respect to vision? The answer is very simple. Light reflex is present, but accommodation reflex is gone. I repeat, light reflex is present, but accommodation reflex is gone, as a result of which any child with diphtheria, even though recovered, you need to ask some questions, and you need to ask the mother, you need to instruct the mother to look for what? Blurring of vision. Instead of blindness, the child will be having blurring of vision. Okay. So it is loss of accommodation, but not loss of light reflex. Light reflex is retained in diphtheria, but accommodation reflex will be gone. An important MCQ. And after 3 to 6 weeks, from third week, definitely you will have descending polyneuritis. You have what? Descending polyneuritis. Okay. Can happen leading to descending paralysis. Rapid diagnosis is Albert Stein. Okay. When will you consider, as we discussed already, exudative pharyngitis, bleeding of the membranes when it is peeled off from the tonsil, but toxicity is more, fever is less. What is the treatment of choice? Answer. What is the treatment of choice? Ram, Nitu. What is the treatment of choice? When they ask you what is the treatment of choice, what will be your first answer? What will be your first answer? What is the treatment of choice with the children with the diphtheria? Azithromycin. Can I give clap to Nitu Patak for saying azithromycin? Or I need to give a clap for a person who is opting for erythromycin or single dose penicillin? So if you think that I need to encourage Duggu and Nitu, both of them are absolutely wrong, my dear children. Neither penicillin nor azithromycin is the treatment of choice. Waiting for your answer right now. The purpose of giving penicillin, single dose benzathine penicillin and azithromycin, but erythromycin for about 10 days to decrease the toxin production. Yes, Ram, it is antitoxin. Diphtheria antitoxin is the treatment of choice. Never ever say you need to know whoever it is. First is diphtheria antitoxin, followed by either a macrolide, whether it is erythromycin or azithromycin or single dose benzathine penicillin for 10 days. So what is the chemoprophylaxis? You need to give all persons, okay, either a single dose benzathine penicillin or erythromycin for 7 days. Some centers have been following macrolide. So now you tell me it is contagious. It can produce this kind of catastrophe in contacts. So how long you need to make isolation of the child? Yes, Ram, erythromycin for 7 days. How long the child has to be kept on isolation? Anyone? Waiting for your answer. An SPM type of question. How long you need to keep the child on? Anyone? Okay, until 2 cultures turned out to be negative. Very good, Ram. 2 negative throat cultures for diphtheria 24 hours apart. Very good. So the carry home message here is: one, death is in the first week is due to what one? Airway obstruction. Second, death in second week is due to myocarditis. Third, death in third to sixth week is due to polyneuritis. The drug of choice is antitoxin. Never ever say either a macrolide or a penicillin. Right? Going to the next one. So what is the diagnosis? Just now it was discussed in detail as a differential diagnosis with respect to membranes in the tonsil. Right now the child is having exudative pharyngitis with, I am not saying hepatosplenomegaly, let me say splenohepatomegaly and generalized lymphadenopathy. Both anterior and posterior nodes are involved in the neck. My children, Nitu, Dugu are absolutely correct. So you are seeing atypical lymphocytosis. Now I am going to ask one question to my kids: which only bacterial infection that causes absolute lymphocytosis, absolute typical small lymphocytosis? Absolute typical small lymphocytosis. Which bacterial infection that produces absolute small lymphocytosis? Waiting for your answer. Viral, you all know Epstein-Barr virus, but I am asking you about a bacterial infection which produces this. I'll wait for 6 seconds. That is associated with that is the clue. That's it, Ram. Pertussis. You need to say pertussis. That is not atypical. That is small typical B lymphocytes. Right. So exudative pharyngitis with hepatosplenomegaly and lymphadenopathy is Epstein-Barr virus unless otherwise proved. One. So what is the clinical clue? Usually when you think that it is group A beta hemolytic streptococci and you start amoxicillin, the child will develop rashes, maculopapular rashes. Lab clue is atypical lymphocytosis. What is the investigation of choice? Yes, Downy cells. What is the investigation of choice for Epstein-Barr virus? Is it PCR or something else? What is the investigation of choice for Epstein-Barr virus? Because Epstein-Barr virus is increasingly being recognized at present both in children as well as in adult. You tell me, what is the investigation of choice? சொல்லுங்க மேடம். ஆமா மேடம். ஒன் டே மேடம். சொல்லுங்க மேடம். ஆமா மேடம். ம். ஆமா மேடம். யூசுவலா அப்படிதான். எப்படி போட்டாலுமே அவங்க வேற மாதிரி மாத்தி தான் அனுப்பும். வியவஸ்தா. போடலாம் மேடம். நம்ம எது போட்டாலுமே அவங்க திருப்பியும் கால் பண்ணும். அதனால நம்ம போடுறத போட்டோம். மேடம் குடுப்போம். அவங்க என்ன பண்றாங்களோ பார்ப்போம். அவங்களே கால் பண்ணி பண்ணலாம் மேடம். ஓகே மேடம். சாரி. So what is the answer? ELISA for antibody. IgM. Ram has opted for IgM antibody. What IgM antibody? So investigation of choice is IgM for VCA. You are good. You are good. So it is IgM for VCA. That is very, very, very viral capsid antigen. So instead of saying just some anonymous terms, you said IgM for VCA. Remember, Paul Bunnell test that we did and monospot test that we did is obsolete right now. It is no longer recommended. Okay, what is the management of choice for Epstein-Barr virus? Is there any management for this viral infection? Is there any management for this viral infection? Remember, usually we don't give any management, but usually there is supportive care. But remember, my dear, there is no role for any 𝐒𝐿 conservative, but it is not so. Remember, when you have two things, one is because of splenomegaly, no contact sports is allowed for the next 3 weeks. Second one is prednisolone you need to consider, my dear. Never ever say only supportive care, supportive care, supportive care, and there is no role for 𝐒𝐿. It is not so. It can produce life-threatening tonsillar enlargement, life-threatening adenal enlargement. It can produce autoimmune hemolytic anemia. It can produce autoimmune thrombocytopenia. In all these conditions, you need to consider prednisolone. An important update for you. So, two things my kids, okay, did not answer. One is IgM for VCA is the investigation of choice. Remember, no contact sport for the next 3 weeks. And remember, prednisolone is indicated whenever there is an airway obstruction, meningitis, or thrombocytopenia. And there is absolutely no role for any antiviral in immunocompetent persons. Right. Next. Okay, now let's start fatafat with respect to TB. Are you all ready? Are you all ready with respect to TB? Okay, right. So what is the, so make it fast. What is the new designation? The old designation has been replaced by National Tuberculosis Elimination Program. Why? Because previously we didn't treat infection, we didn't treat contact, but right now we are treating infection. That means Manto positive, IGRA positive, and also people living with the contact, people living with that by household contacts living with pulmonary TB cases are getting prophylaxis. That's why we are trying to eliminate even infection. Previously, we were trying to concentrate on disease. Right now, we are concentrating on infection. As a result of which, it is called as National Tuberculosis Elimination Program. And you all know that pediatric suspected TB case. So, who is the pediatric suspected TB case? Okay, so who is the pediatric suspected TB case? So, you all know. Very simple. What are all the 4 points that you need to know? So, what are all the 4 points that you need to know with respect to TB? Okay, what are all the 4 points with respect? No, Ram, previously it was less than 5 years old. Ram, previously it was less than 5 years old. Right now, not even 5 years. Almost all people living with them, irrespective of the age group, irrespective of the HIV status, they will be receiving INH prophylaxis or HR prophylaxis or a combination of isoniazid or rifampicin. Please. So it is not less than 5 years. INH prophylaxis is indicated to all contacts with the pulmonary TB cases irrespective of age and sex. Night sweats, weight loss, 2 weeks. Nitu, that is mainly for adult. As far as pediatrics is concerned, we don't include night sweats. Only in TB and HIV we include night sweats, but we don't use night sweats in pediatric age group. It is persistent fever of more than 2 weeks, persistent cough for more than 2 weeks, along with weight loss 5% over a period of 3 months, along with your contact who took ATT in the past 2 years for pulmonary TB. This is you all know. But my question is, what are all the findings in X-ray chest? What is the next investigation of choice? Is it Manto, X-ray or CB naught? Is it Manto, X-ray or CB naught? What is the next investigation of choice? Is it Manto, X-ray or CB naught? Tell me. An index case you are suspecting based on fever 2 weeks, cough 2 weeks, weight loss 5% in the past 3 months. X-ray, very good. It is not CB naught, it is X-ray. And what are all the 3 important points in this X-ray? What are all the 3 important findings which will make you to go for no, Nitu? No, extremely sorry. The next investigation of choice in all suspected TB is chest X-ray. Chest X-ray should be done up front. It is not CB naught. So if chest X-ray shows hilar adenopathy, miliary pattern or cavity, if chest X-ray shows hilar adenopathy, miliary pattern or cavity, then you need to go for very good, very good. Again, we don't mention Ghon's complex, my dear Ram. We mention hilar adenopathy, miliary mottling, and cavity. Instead of Ghon's complex, it should be replaced by cavity. If these things are present, then go for CB naught. If these 3 things are absent, you need to go for an antibiotic. That antibiotic should not be levofloxacin. That antibiotic should not be linezolid. So remember, my dear friends, questions can be based on this. So when you have a suspicious TB case, based on fever more than 2 weeks, cough more than 2 weeks, and weight loss 5% in the past 3 months, and contact took ATT for pulmonary TB in the past 2 years. So then you need to do an upfront chest X-ray. If chest X-ray shows hilar adenopathy or miliary pattern or cavity, then you need to go for CB naught. If the chest x-ray is not suggestive of that, then you give a trial of antibiotic, probably amoxicillin or amoxicillin clavulanic acid. Never give linezolid or levofloxacin without ruling TB. Okay, right. Don't say gone complex. Majority of you had voted for gone complex. It is not gone complex. It is just say hilar adenopathy. Hilar adenopathy, which itself indicates that gone complex. Okay, right. Second one is miliary mottling. Third one is cavity. Third one is cavity. Okay, right. Okay, next question. What is the manto that you use? What is the manto that you use? What is the manto that you use, and what manto is said to be positive? What manto is said to be positive? Anyone, what manto is said to be positive? Is it 1 to you, 1 TU, 2 TU, or 5 TU? Which one is you need to give? Don't, which one you need to give? 1 TU, 2 TU, 5 TU. So 1 can produce false negative. 2 TU is the ideal. 5 TU can be used. 10 TU should not be used. 20 TU should not be used. So ideal is 2. If not possible, 5. Never ever use 10, 20 and 1. Okay, as you all know, more than 5 millimeter is said to be, as you all know. Okay, as you all know, more than 5 millimeter in case of immunosuppressed and more than 10 millimeter in case of immunocompetent is said to be infection. It doesn't mean that it is disease. Is it said to be infection? Right. So what is the point of care test for yes, 10 millimeter and above in immunocompetent, 5 millimeter and above in immunosuppressed? So my question is, Arun and Shiva, my question is, what is the point of care test? What is the point of care test? Anyone? What is the point of care test? Is it LPA or MG80 or CB0? Which is the point of care test? Waiting for your answer. What is the point of care test? The point of care test is your CB0. Very good. Say sputum CB0. It is the point of care test. What is the investigation of choice for drug resistant cases? The next question is, what is the investigation of choice for drug resistant cases? Because we are not doing phenotypic resistance. Right now you are identifying genotypic resistance. So the investigation of choice is both LPA line probe assay as well as CB0, because CB0 is going to say R sensitive or R resistance now. But the gold standard test is liquid culture medium and not solid culture medium, and it is mycobacterial growth indicator tube system. Remember, MGIT will determine 16 bacilli per ml, whereas your CB0 will detect 161 bacilli per ml. Whereas there is something we are going to get, already got, which is called ultra CB0. Ultra CB0 is very sensitive test. Again, this ultra CB0 will pick up 16 bacilli per ml like your MG80. But as of now, the point of care test is CB0. The point of care, the investigation of choice is MG80 liquid culture medium. And the investigation of choice for drug resistant cases is line probe assay. Right? Okay, then let me go for the next one. MDR, all my kids know. What do you mean by MDR? What do you mean by pre-XTR? What do you mean by XTR? I am waiting for your answer because there is a little bit of change as per recent WHO guidelines. There is a little bit of change in recent WHO guidelines. I am waiting for my kids to answer in chat box of YouTube. Yes, I am waiting. MDR. Yes, MDR, all of you know, resistant to H and R. What is pre-XTR and what is XTR? Yes, Duggu, Siva, Ram, I know my kids are very confident with the first question. What is the answer for the second pre-XTR and what is the answer for XTR? I am waiting for my kids to answer. Ram has mentioned pre-XTR means Ram, Nithik, MDR-TB plus 1 fluoroquinolone. What do you mean by XTR-TB? What is mean by XDR-TB? So, pre-XDR plus additional group A drug. Very good. Fantastic. What are group A drugs? What are group A drugs? Right now, Shiva, Prasad, Rantalla. Right now, we do not use the term aminoglycosides, my dear boy. We are avoiding that aminoglycosides unless otherwise it is indicated. So, it doesn't stand in the definition. So, pre-XTR is very good, Ram. Pre-XTR is HR plus 1 of the quinolones. XTR plus, what is XTR? HR plus 1 of the quinolones plus a first line drugs, that is your linezolid or bedaquiline. Very good. Levofloxacin is quinolone. Already it comes under pre-XTR. Why you are adding levofloxacin again in this one? And you cannot add because quinolone means levofloxacin. So pre-XDR is one of the quinolone. XDR is quinolone plus either linezolid or bedaquiline, that is XDR-TB. Okay, waiting for your answer. Why is there any role for extended intensive phase? After 2 months of beautiful compliance and appropriate drug dosage, the child is not responding. Do I need to do anything further? What is the role of extended intensive phase? What is the role of extended intensive phase? Answer. Answer. What is the role of extended intensive phase? Is there any role? Waiting for my kids to answer. Shall I extend phase for 1 more month? My tuberculoma is not reducing. My pleural effusion is not reducing. My parenchymal infiltrates are not reducing. Should I reduce the dosage? Yes. What is the role of extended intensive phase? No one is answering. Waiting for my kids to answer. Nithu, Siva, Ram, Patak. Come on, there is no role for extended intensive phase. It is 2 months of intensive phase with HRZE. There is no role for extension phase. If you want to extend, it means that you are dealing with a case of drug resistant TB. Right. What is the role of continuation phase? Yes. Where are you, my dear kids? What is the role of continuation phase? What is the role of continuation phase? What is the role of what happened? Why my kids are not answering? So, continuation phase is indicated in two conditions. One is bone and joint TB, another one is neurotuberculosis. Steroids are given in endobronchial TB, CNS TB, as well as TB involving the adrenal gland. Okay, and then TB pericarditis. Grave mistake. I missed TB pericarditis. So, endobronchial TB as well as in TB pericarditis. pericarditis. Okay. Now, what happened to my kids? What is the newborn with the mother on ATT? Newborn with the mother, the child is having. So, what is the treatment for newborn with the mother on ATT? Or my kids answering or having hypoglycemia? Waiting for your answer. So, when a mother with the mother on ATT, so mother, so what will you do when the mother is on ATT? Prophylactic INH. 1 second. Okay, now what happened? Mother on ATT, what will you do? So the answer is simple. So will you give BCG vaccination? Will you give BCG vaccination? So the question is drug sensitive TB, mother is drug resistant TB. Drug sensitive TB vaccination I will give, drug resistant TB vaccination I will give. One. Second one, will you give breastfeeding? So now question is drug sensitive TB, drug resistant TB. Drug sensitive TB, direct breastfeeding. After 2 weeks, first 2 weeks with the mask. Drug resistant TB, expressed breastfeeding. Don't stop, don't stop. Expressed breastfeeding. Third one is can I put the child on prophylaxis? My kids had INH, mentioned INH. Apart from INH, can we do something else? So again, drug sensitive TB and drug resistant TB. Drug sensitive TB, INH can be given to the child after birth for 6 months. Drug resistant TB, recently WHO has mentioned levofloxacin can be given for 6 months. Levofloxacin can be given for 6 months, and remember BCG vaccination can be given for both. I repeat, BCG vaccination can be given for both. Right? Very good. So, right, newborn with the mother on ATT. So, you all know what is the app for reporting TB? It is NEET. It is what? NEET. Right. So, okay, right. So please do not forget about these things. A simple one. So drug sensitive TB, drug resistant TB. So what is the role of prophylaxis? One. Second one is breastfeeding. Third one is isolation. Fourth one is vaccination. Prophylaxis in case of drug sensitive TB. Prophylaxis in case of drug sensitive TB is INH. Prophylaxis in case of drug resistant TB is levofloxacin. Breastfeeding. This is direct breastfeeding. Here it is expressed breastfeeding. Isolation is not required, but isolation required in case of DRTB, and then vaccination is indicated in both. Vaccination is indicated in both. Vaccination is indicated in both. That's it. Okay. Right. Then let's come to nephrology. So are you all okay? Shall we go to nephro? Okay then. So what is the now I have two kids, one kid with this kind of urine, another kid with this kind of urine. So what is the answer for the first one and what is the answer for the second one? Shiva, Nituk, Duku. Tell me what is the answer for the first one and what is the second for next one? So this is bright colored urine. The first one is bright colored urine. The second one is cola colored urine. So cola colored urine is always glomerular hematuria. Cola colored urine is always glomerular hematuria. Colored urine is always glomerular hematuria. Whereas your red colored urine, glomerular hematuria, whereas red color urine is non-glomerular hematuria. Is non-glomerular hematuria. Okay, right. Then, okay, then. Let me ask some fatafat questions for you. So you answer because I have not animated the answer for a nephrotic syndrome. So let me ask you one question. So based on that, you need to answer. So first question is, first question. So what is the duration of first episode? What is the duration of treatment for first episode? Second, what is the duration for first episode? So duration first episode. Treatment first episode. Second, what is the role of serum cholesterol in the diagnosis of nephrotic syndrome? Second. Third question, is there anything called treatment resistant nephrotic syndrome? Is there anything called treatment resistant nephrotic syndrome? Next, what is the treatment for edema in nephrotic syndrome based on the amount of weight loss? 6 weeks, that's it. Oh, edema, okay. What is called steroid resistant nephrotic syndrome? Tell me the recent guidelines for this. Duration of first episode. What is the role of serum cholesterol in nephrotic syndrome diagnosis? Treatment of what is called treatment resistant nephrotic syndrome. What is the management of edema? What is the definition for SRNS? Nitok, just 6 weeks, is it enough, my dear girl? Is it enough? Nitu says 6 weeks, Dugu says 6 weeks. They are absolutely wrong. Dugu says serum cholesterol is increased. I am coming with the new things, but okay. How much serum cholesterol you need to have, my dear Dugu? How much serum cholesterol you need to have, Dugu? Resistant proteinuria persists even after 4 weeks. Nitu Patak official, sir, for alternative day therapy. Okay. So let's come up with the new things in steroid sensitive nephrotic syndrome. Right? So the recent definition says there is no role of serum cholesterol in the diagnosis of nephrotic syndrome. What you need to do is prove hypoalbuminemia. Hypoalbuminemia means your serum albumin of less than 3 grams per deciliter. Where it is getting lost? Urine. So you need to have some proof in urine. The spot PCR of more than 2, or you can have more than 40 milligram per meter squared per hour, 40 milligram per meter squared per hour, or urine albumin 3 plus or 4 plus. Urine albumin 3 plus or 4 plus. Okay. There is no role for at present. There is no need to have serum cholesterol as a diagnostic criteria. Now, lack of steroid resistant means daily therapy. I repeat, steroid resistant means daily therapy for 6 weeks. Someone answered, Nitu, you had answered 4 weeks. No, persistent proteinuria despite daily therapy for more than 6 weeks as per Indian Society of Nephrology Guidelines 2021. Treatment, do not say just 6 weeks. You need to say 2 mg per kg daily for first 6 weeks, followed by 1.5 mg per kg on alternative days. 1.5 mg per kg on alternative days for next 6 weeks. So total are we have 12 weeks of nephrotic syndrome first episode therapy. So what is called a frequent relapse? When you have two or more, not two, when you have two or more in the first 6 months, okay, three in any 6 months, or more than four relapses per year is called as frequent relapse. Now let me ask you one question. What is the treatment for frequent relapse or steroid dependent nephrotic syndrome? Steroid dependent nephrotic syndrome means either the child relapse on alternative day therapy, whether the child relapses on alternative day therapy, or within 2 weeks of stopping, alternative day therapy, either on alternative day therapy or within 2 weeks of stopping alternative day therapy. If the child relapses, we call it a steroid dependent nephrotic syndrome. So Nitu, sir, alternative day therapy. Nitu, what for is that answer? I don't know. What is the treatment for both steroid dependent nephrotic syndrome as well as the answer for this one? What is this? One is steroid dependent nephrotic syndrome. Second one is a frequently relapsing nephrotic syndrome. What is the treatment for it? I am waiting for your answer. Nitu, Siva, Duggu, Ram, what is the treatment for steroid dependent or frequently relapsing nephrotic syndrome? Nitu has said, Leave my soul. Waiting for Siva, Duggu to answer along with Ram. What is the answer? What is the answer for frequently relapsing as well as steroid resistant nephrotic syndrome? Azathioprine and cyclophosphamide for resistant. So what do you mean by that? What do you mean by that? Azathioprine and cycle. This is an often asked question in NEET as well as in INI-CET. No, my dear boys and girls. Step 1, step 2, step 3. Step 1 is you need to give alternative day prednisolone 1.5 mg per kg for 4 weeks in case of relapse. Then slowly you need to taper. What do you mean by slowly you need to taper? Listen carefully. When you have a frequently relapsing nephrotic syndrome or you have a steroid dependent nephrotic syndrome, what you need to do? So you need to treat that relapse. So relapse means what? You need to give 2 mg per kg per day of prednisolone daily till remission occurs. For example, it takes 7 to 10 days. Remission means what? 3 days of proteinuria, no proteinuria or 1 plus proteinuria. Then after 3 days of remission, you need to give 1.5 mg per kg on alternative days for 4 weeks. Usually you will stop, but instead of stopping, what you need to do? So for example, let me say July 10 to July 10 to 20 you are giving this one, or let me say July 20 to 30 you are giving. The child is having a relapse and you are taking time to for remission. So then August 4 weeks you need to give 1.5 mg per kg on alternative days. Then what you need to do? So September, instead of giving 1.5, you give 1.25 mg per kg on alternative day. October, you give 1 mg per kg alternative day. October. November you give 0.75 mg per kg on alternative day. And then December you give 0.5 mg per kg on alternative day. So this 0.5 mg per kg per alternative day should be given for 6 months to 1 year. So now many of my kids have opted for levamisole, azathioprine and cyclophosphamide. My question is frequently relapsing or steroid dependent nephrotic syndrome. So what you need to do, if the child getting relapse, so if you are able to give either 0.5 mg, okay sir, this was when steroid fails, okay then. My question is frequently relapsing nephrotic syndrome. Everyone knows about steroid resistant, my dear boss. Everyone knows about steroid resistant. My question is steroid dependent is frequently asked. Even there are some issues with respect to steroid resistant. Let me teach you. So 0.5 mg per kg. So if you are able to maintain either 0.5 to 0.75, then it's okay. But if the child requirement is 1 mg per kg on alternative days, then comes the role of steroid sparing agents. Then comes the role of steroid sparing agents. So what are all the steroid sparing agents? Steroid sparing agents are levamisole, cyclophosphamide, etc. So you need to try low dose alternative day prednisolone therapy. Then only you can go for levamisole if the requirement is more than 1 mg per kg per alternative day. Okay? Right. Right. So this is called low dose alternative prednisolone therapy in steroid dependent and frequently relapsing nephrotic syndrome. Right. So the plan is prolonged alternative day steroid therapy. Now my question is, the child is having prednisolone on alternative days. Now the child is developing infections. What will you do with this infection? The child is on alternative prednisolone therapy. The child has got viral URI. My question is, what will you do? Either you will stop steroids or continue steroids or increase the dose of steroids. Answer. Nitu, Dugu, Ram, answer. What is the answer? What is the answer? So the answer is, instead of reducing or stopping, alternative day therapy should be continued to daily therapy. Should be continued to Alternative day therapy should be continued to daily therapy for 7 days. Why? Because this viral infection will cause relapse. Rather than worrying about steroids, you give steroids, the child will be doing fine without any nephrotic syndrome. Okay? Right. Continue with the increased dosage with the daily. Very good, Nitu. So steroid sparing agents are only when the prednisolone requirement is more than 1 milligram per kilogram per day. Right. What is called difficult to treat nephrotic syndrome? Steroid resistant is different. Difficult to treat nephrotic syndrome is different. Answer. Answer. What is difficult to treat a nephrotic syndrome? This is an important concept introduced in 2021. One is frequent relapses. Significant toxicity, failure of 2 or more steroid sparing agents such as levamisole, cyclophosphamide, etc. Okay, that is called difficult to treat. The treatment for difficult to treat is calcineurin inhibitor like cyclosporin or tacrolimus. If not responding, you need to go for rituximab. you need to go for rituximab. CNI is calcineurin inhibitor. Next, what is the management of edema in nephrotic syndrome? An important question. It can be mild, moderate to severe. Mild means less than 7%. You need to go for salt restriction diet. That's all. Moderate to severe means more than 7% of body weight. Apart from dietary restriction, you need to give diuretics such as furosemide, spironolactone, metolazone, thiazide or IV infusions, etc., based on the severity of edema. At times, despite being edematous, the child can present with shock because it is basically from the intravascular volume to extravascular volume. So, in the presence of hypovolemia, you need to give normal saline bolus followed by albumin infusion, then give furosemide, so that when you give normal saline, the shock will be corrected. When you give albumin, that fluid that is present in the extravascular compartment will come to intravascular compartment. Then you give furosemide, the child will be doing fine. Okay, will be doing fine. Okay, right. So remember, difficult to treat asthma, you need to know. Difficult to treat asthma, you need to know. Okay, this is again, this is once asked. Okay, right. Okay, now spotters. So I must be waiting for my kids to answer before going to the next slide. Spotter. So what is this? So let me write. So what is this? What is this? Let me say this is unilateral kidney. This is unilateral kidney. This is unilateral kidney. This is newborn. What is the diagnosis? Nitu, I will provide you the slide. Don't worry, my dear boy. It will be sent as annotated PDF notes. Don't worry. Okay, now tell me, what is this? Unilateral kidney in a newborn. So I am waiting for my kids to answer. Nitu, Dugu, Ram. So what is the answer for this one? Unilateral kidney, newborn. No one is answering. Waiting for you to answer. Yes, waiting for you to answer. So if you say autosomal dominant polycystic kidney, you are wrong. If you say autosomal recessive polycystic kidney disease, you are wrong. So what is this? This is called multicystic dysplastic kidney. This is called multicystic dysplastic kidney. Okay, so this is called multicystic dysplastic kidney. Very good, Shiva. Very good, my dear boy. So this is unilateral and this is a non-functioning kidney. Non-functional kidney. Remember, once in INI-CET, they are asking such kind of difficult question. When you have this on one kidney, what the other kidney associated condition will be with it? So one is the other kidney can have vesico-ureteric reflex, or you can have a posterior urethral wall. Posterior urethral wall. Other kidney. Surprisingly, this kind of difficult question at sometimes they will be asking in INI-CET. So this is multicystic dysplastic kidney. And what is the treatment of choice? Just observe. Majority of the time they will resolve by 5 years. They will resolve by 5 years. If not, very rarely they can go for nephrectomy. Very rarely they can go for nephrectomy. And so this is over. And the next one is, what is this? So this is a boy with a recurrent UTI with elevated urea, elevated creat, and the boy is having elevated blood pressure. The child is just 2 years. So what is the diagnosis for the one on the right? What is the diagnosis for the one on the right? Very good. The first question that you need to ask in any case of a child with recurrent UTI, particularly if it is a boy, means stream, whether it is a good stream or poor stream. Stream of urine, whether it is a good stream or poor stream of urine. So this is MCU of the child with the recurrent UTA, and it shows dilated posterior urethra. It is dilated posterior urethra. Okay, this is dilated posterior urethra. It is nothing but posterior urethral wall. The treatment of choice is transurethral fulguration. Transurethral fulguration. This is transurethral fulguration is the treatment of choice. Very good, keyhole sign. Next, now you tell me what is the difference between a simple difference between hematuria, a simple difference between nephritic and nephrotic. This is not that tough. Hematuria is often a manifestation of nephritic but not of nephrotic. Proteinuria is a manifestation of nephrotic but less of nephritic. Ascites is a manifestation of nephrotic. Nephrotic usually less than 3 years. Nephrotic usually 3 to 6 years. 6 years. Hypertension is more often a manifestation of nephritic but less often a manifestation of nephrotic. Cast here is RBC cast. Cast here in nephrotic is fatty cast. Urea and creatinine usually are elevated in nephritic but normal in minimal change nephrotic syndrome. Complication in nephritic, you can have elevated blood pressure leading to congestive cardiac failure or stroke. It happened. Nephrotic syndrome complications are spontaneous bacterial peritonitis, increased thrombosis, okay, spontaneous and then dehydration can happen. Genital edema is a feature of nephrotic syndrome. Genital edema is a feature of nephrotic syndrome, right? Next question. I am waiting for you. I am waiting for my kids to answer. What is the answer for first one, second one, third one, fourth one, fifth one? Let me wait till you complete your answer in chat box so that I can start mine. Yes. Nito, Ram, Duko, waiting for your answers. Brain abscess. Brain abscess is not that common, my dear boy. Brain abscess is a feature of tetralogy of Fallot. It is not that common in nephrotic syndrome. Answer. What is the answer for A, B, C, D, E? I had given you 5 one-liners. These 5 one-liners will be of very much use to crack your entrance examination. Waiting for it. Yes, waiting for your answer. polyuria, failure to thrive, glycosuria, aminoaciduria, and metabolic acidosis. That's it, Nico. Fanconi. Niktu, you tell me what is the most common cause for Fanconi in pediatric age group? What is the most common cause for Fanconi in pediatric age group? Nitu, waiting for your answer. Most common cause for Fanconi in pediatric age group. Ram, Dugu. So it is cystinosis and Lowy syndrome. Very, very important. It is cystinosis and Lowy syndrome as the most common cause for Fanconi syndrome. So what is the second one? Polyuria, metabolic alkalosis, hypercalciuria, hyponatremia, hypokalemia. Answer. Answer. Polyuria, metabolic alkalosis, hypercalciuria, hyponatremia, and hypokalemia. What is the answer? Yes, not that tough. Yes, Dugo, it is Bartter syndrome. Third one, minimal metabolic alkalosis, but the child is having tetany, hypomagnesemia, which in turn can produce exercise-induced muscle cramps. What is this? What is this? The one which involves distal convoluted segment. Very good, Nituma. Very good. Gentleman. Hyperkalemia with the metabolic acidosis is a manifestation of hyperkalemia with the metabolic acidosis is a manifestation of what? Hyperkalemia. It is type 4 hypoaldosteronism, that is pseudo hypoaldosteronism. And finally, hypernatremia with polyuria. Hypernatremia with polyuria. Hypernatremia with polyuria. Waiting for your answer. Very simple. I will give one more clue. Hypernatremia with polyuria. Here the serum osmolality is more than 300 and the urine osmolality is less than 300. What is the diagnosis? What is the diagnosis? The diagnosis is very simple, very good. Diabetes insipidus. When will you do water? No. You are wrong. Water deprivation test is not for all. When will you do water deprivation test? It is diabetes. When your serum osmolality is normal, that is between 280 to 300. But your urine osmolality is less than 300. This is when you need to do water deprivation test. Normal serum osmolality with reduced urine osmolality. Whereas when you have a high serum osmolality with low urine osmolality, it is confirmative of diabetes insipidus. I don't think you need to do any further investigation, right? Okay. Now, fatafat. Shiva, Duko. Okay, Nito, now you answer. I am waiting for you to open my discussion on this. Most common cause for recurrent UTI. Second most common cause for recurrent UTI. What is the treatment for grade 1 and 2 VUR without bladder bowel dysfunction, with bladder bowel dysfunction? Grade 3, 4 and 5 VUR with the bladder bowel dysfunction. What is the treatment? So tell me your answers, please. So Nitu, Siva, Dugu, waiting for your answer. Ram, most common cause for recurrent UTI. Answer. Everyone answer. Okay, don't answer one by one. You need to answer You need to answer kidney transplantation. Okay, waiting for your answer. Kashif has mentioned kidney transplantation. I don't know what for is that. So let me wait for 1 minute for my kids to answer each and everything as a single post. Don't do, don't do multiple posts. Single post for all answers. Single post which comprises 1, 2, 3, 4, 5, 6 answers in a row. Waiting for you. Because there are so many bombs are waiting. So many bottom bombs are waiting in this new change of guidelines. Yes, yes. Answers. There are no further answers. Okay, let me start. Most common cause for recurrent UTI is bladder bowel dysfunction or constipation. Second most common cause for recurrent urinary tract infection is vesico-ureteric reflux. Okay. So, Nitu, first question wrong. Treatment for grade 1 and 2 VUR without bladder bowel dysfunction is nothing. Nothing. No antibiotic prophylaxis is needed. Treatment for grade 1 and 2 VUR with bladder bowel dysfunction, that is constipation, is antibiotic prophylaxis. Whereas grade 3, 4 and 5 with bladder bowel dysfunction, you need to give antibiotic prophylaxis till the bladder bowel function becomes normal. When despite being on antibiotic prophylaxis in grade 3, 4 and 5, the child develops recurrent UTI, then bilateral ureteric reimplantation. So all or no. So rest you don't know nothing, my dear boy. So we are here to teach. So look at this. All are new things, my dear boy. The recent guidelines have changed a bit. The recent guidelines have changed a bit so that I had everything from the recent guidelines. Okay. Okay. So if you are comfortable with this slide, let me go for the next one. If you are comfortable with this slide, let me go for the next one. Because these are all new with the minimal change. Nito, Siva, Dugu, shall I go for the next one? Okay, then what are all the drugs used in uroprophylaxis? What are all the drugs used in uroprophylaxis? Dugu, Siva, Nito, Ram, what are all the drugs used in uroprophylaxis? It is only three drugs. One is nitrofurantoin, the second one is cotrimoxazole, third one is cephalexin. Tell me what is the indication for ultrasound abdomen and what is the indication for MCU or DMSA. Waiting for your answer. Again, there are some time bombs are waiting for you. In UTI. Answer, indication. All cases of UTI, we need to take an ultrasound abdomen. And what is the role of MCU and DMSA? Particularly DMSA. When MCU should be done? MCU should be done 2 weeks after UTI. DMSA should be done 6 months after UTI. Very good, Nito. Indications for MCU. Okay, right? Then indication for MCU is all first episode non-E. coli UTI. All first episode non-E. coli UTI and first episode non-E. coli UTI you need to do MCU, and recurrent E. coli UTI you need to do. These are all the indications for MCU. And if MCU shows some deformity, then you need to go for MCU after 6 months of UTI, because many of the time it will find out the scar which is usually in the resolving stage. That's why you need to take a break of 6 months before doing an MCU. No, no, no. Abnormal MCU go for DMSA 6 months after the episode of UTI to find out the permanent scar rather than transient scar. Transient scar will be there in the first 6 months, so that you need to get the cutoff of 6 months to get the permanent scar. Okay, so going for the next one, nutrition. Shall we take break for 5 minutes? If you want, break for 5 minutes. If you want, or shall I continue? Just 5 minutes, not more than that. Okay, sir. Okay, just 5 minutes. Now the time in my watch is, in my phone is 12:47. I will be back by 12:55 sharp. 12:55 sharp. So a break for about 5 minutes only. Just 5 minutes only, not more than that. I'll be there within 5 minutes. Be on the line or else get something to eat. Just 5 minutes break. I'll be on online. Yes. So we'll start the game again. I'm extremely sorry. Uh, Tony DB has voted for Kawasaki. Uh, Very good. Indeed, even though it is too much. So it is under the name nutrition. So you need to vote for nutrition related things rather than going for Kawasaki. And it is not that much bulbar conjunctivitis, my dear boy. It is not that much bulbar conjunctivitis. So it is basically a circumcorneal congestion suggestive of B12 deficiency. Okay, very good. Right. So let start our second part right now with a bang indeed. Right. So the first one is circumcorneal congestion. So people used to say whenever you have cheilitis and whenever you have glossitis, invariably all of you will be voting for B12 deficiency. But the question is how many of you will be voting for circumcorneal congestion? So it is circumcorneal congestion. Congestion is suggestive of B12 deficiency, right? Then what is this? The one on the left side and one on the right side, you have some desquamating lesions, pigmentations, hyperkeratosis in glove and stocking area, and the one on the right side with alopecia with seborrheic dermatitis. So what is the answer for this one? Shreya has voted for B2 deficiency. Shiva Prasad has voted for biotin deficiency. Shreya, so what is this? This is nothing but biotin. The one on the right side is biotin. This is biotin. When you have alopecia, when you have a neuroregression, when you have a alopecia, when you have neuroregression, when you have developmental delay, when you have multiple convulsions, then you need to think in terms of multiple carboxylase deficiency. I repeat, multiple carboxylase deficiency, which is due to dependent on biotin. Very good. Next one. What is the one on this? Color. This is sun exposed area, necklace area. What is this? Is this biotin? No, this is, what is this? This is not biotin. Pellagra niacin deficiency. Whenever I give necklace area distribution, invariably it will be easy for you to answer, but without that photosensitive areas, acral, you need to think in terms of as Siva Prasad. It is niacin deficiency, right? What is the deficiency of this? What is the deficiency of this? Waiting for you to get my answer in YouTube message box. What is the answer for neural tube defect, and what is the answer for this one? Hyperpigmentation involving palms and soles. Siva, Shreya. Okay. So apart from folic acid, my dear friends, when you see a neural tube defect, invariably it will be easy for my children to diagnose folic acid deficiency. It will be easy for them to diagnose folic acid deficiency. But apart from that, please remember zinc deficiency can cause, maternal vitamin A deficiency can cause neural tube defects. Apart from folic acid, it can be caused by zinc deficiency, as well as it can be caused by maternal vitamin A deficiency, right? So knuckle hyperpigmentation is suggestive of B12 deficiency. Yes, you all know that. So what is the difference between folic acid deficiency and the B12 deficiency with respect to lab parameters? With respect to lab parameters, both are associated with hypersegmented neutrophils. Both are associated with the macrocytic anemia. Hypersegmented neutrophils means more than 5 lobes. In at least 5% of neutrophils, are identification of even a single neutrophil with the 6 segments. Macrocytes means more than 100 femtoliters. Very good. Dugu, as Dugu told, methylmalonic acid is increased in case of B12 deficiency, whereas in folic acid deficiency, it will be normal. Folic acid deficiency, it will be normal. And remember, methylmalonic aciduria, methylmalonic acid levels has literally replaced your Schilling test right now. It is not Schilling test right now we are doing. Right. Okay. So what is this? You all know. The answer is not that tough. What is this? What is this? What is this you are seeing here? What is this you are seeing here? What is this you are seeing here? Waiting for you. What are all these three things that you see? Okay. Yes. This is rickety rosary. So this is rickety rosary. And what you are seeing is cupping, fraying, widening. What you are seeing is cupping, fraying, widening of epiphysis. Cupping, fraying, widening. And what you see on the right more metaphyseal cupping. Okay, Nasa edge, Duggu, Siva, Shreya. What is the one that I had marked on the right extreme corner just above my head in the bone? What is this actually? Nasa, Duggu, Shreya. What is this actually? The one on the rightmost corner, this one, this area. What is this? What is this? So what is this? Very good. Fantastic. Dugu, you are correct. Name it. You are saying healing rickets. Name it, my dear girl. What is that? Name it. That's very, very important one. What is that? So this is called as, waiting for my kids to answer in the chat box. What is this? This is called zone of provisional calcification. This is zone of provisional calcification, which occurs 4 weeks after vitamin D therapy. Which occurs, okay, Dugo, this is called zone of provisional calcification, which occurs 4 weeks after vitamin D therapy. And finally, let me tell you, okay, follow me. Within a minute, we are going to complete rickets scenarios. Within a minute. Okay. So point number one, whenever I have rickets, the first thing I will see is pH. If the pH is low, 7.2, less than, I'm sorry, if the pH is less than 7.3, invariably either it can be a distal renal tubular acidosis or proximal renal tubular acidosis. What you will do urine pH. What you will do urine pH. If urine pH is more than 5.5, your diagnosis is distal renal tubular acidosis. If your urine pH is less than 5.5, it is proximal renal tubular acidosis. This is segment number 1. Then segment number 2, if your pH of the blood is normal, then you need to look for phosphorus. Then you need to look for serum phosphorus. If serum phosphorus is high, I repeat, if your serum phosphorus is high, then you need to look for parathyroid hormone. If parathyroid hormone is also high, it is chronic renal failure, renal osteodystrophy. If the parathyroid hormones are low, then it is hypoparathyroidism. Segment 2. Then segment 3. If phosphorus is low, but your PTH is high, then I will look into two things. One is 25OH-D3, another is 125OH dihydroxy D3. When 25 OH-D3 is low, it is nutritional rickets. It is nutritional rickets. If 125 is low, it is vitamin D dependent rickets type 1. If 125 D3 is high, it is VDDR type 2. Over. And the only condition in which phosphorus is low, but PTH is normal. The only condition is X-linked hypophosphatemic rickets. That's all. This one page, take a screenshot, is the shortest, to be frank, cutest approach to rickets in one slide. Another simple thing is less than 6 months. Okay, it is non-nutritional rickets. Point number 1, when you have alopecia in rickets, it is VDDR 2. When you have dental abscess and lower limb involvement, it links X-linked hypophosphatemic rickets. That's it. That's it. This single page contains your lifetime approach to rickets in a single slide. Take a screenshot. Even though I am going to transfer as an annotated PDF, please take a screenshot. Okay, shall I go for the next slide? If you apply this, I bet at least 1 or 2 questions in NEET or INCT or FMG you will be correct. Okay, shall I go for the next one? If you say so. Okay, right. We don't have time. I'm moving to my next slide. Please take a screenshot. Okay, then let me go to the next slide. Done, Siva. Okay, that's it. So, what is this? The answer is very, 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 very easy. I don't think it is so much difficult to my kids. The answer is very, very easy. Perioral, perianal, acral dermatitis. What is this? What is this? This is zinc deficiency. This is zinc deficiency, congenital zinc deficiency, autosomal recessive. Apart from this, you have low cell-mediated immunity predisposing you to infections. Apart from that, you can have hypogonadism, you can have agesia in zinc deficiency. Okay? Yes, you are all familiar with that. So the treatment of choice is 1 mg, 1 to 2 mg per kg per day, lifelong zinc. Okay, next one. So again, it is very, very easy. I will be waiting for you. Choose your answers. Choose your answers. I will be waiting for you, waiting for about a minute or two to find out your answers. Yes. Let me see. So you need to post a single message which includes all. Time will be given to you so that you can think and answer. Please. Answer. Somewhat little bit difficult certain questions, but you need to answer. So shall I start or you want to answer? Shall I start? Shall we? Okay, Wimberger sign. You all know Wimberger sign is associated with. So let's start one by one. Come on, my dear kids. Must be in hyperphagia, va? Must be in not hyperphagia. Must be in postprandial status, hyperglycemia. Sivaprasad Rantalla. First question. Wimberger sign is associated with scurvy. Correct? Not a difficult one, my dear boy. Correct. Rhinoderma toad skin. So, can anyone correct Sivaprasad? Sivama, apart from zinc, vitamin A, I repeat Siva, it is essential fatty acid deficiency. It is essential fatty acid deficiency. So, Phrinoderma is due to zinc, vitamin A, essential fatty acid deficiency. Okay, Sivama? Painless rosary. Again, it is. Painless is what? Rickets. Whereas painful is scurvy. Scurvy. Okay, right. Then corneal vascularization and photophobia is due to what? Corneal vascularization and photophobia is due to what? It is due to, you all know, just know, B2 deficiency. Reduced activity of sodium pump. Surprisingly, voracious appetite in which deficiency? Surprisingly, I repeat, surprisingly, both answer is thiamine. Both answer is thiamine. Okay. Which vitamin deficiency manifests during corrective therapy of protein energy malnutrition? It means it is the disease of growing dash. Again, rickets, vitamin D. Okay. Posterior column and cerebellar dysfunction. The answer is very easy. B12. Hemorrhagic manifestation. The answer is, you know, scurvy. Convulsions, hypochromic, microcytic anemia, and oxaluria. I am going to wait for this answer. Convulsions, hypochromic, microcytic anemia, along with oxaluria. I am waiting for your answer. That's it, my dear Siva. That's it, my dear. It is pyridoxine deficiency. It is pyridoxine deficiency. Very good. That's it. Now let's go to the next one. Okay. The answer is very, very easy. Low height for age. What does it mean? Low height for age. Low height for age. So what does it indicate? Low height for age is stunting. Low weight for height is wasting. Low weight for age is undernutrition. Nutrition. Stunting is chronic. Low weight for height is acute. Low weight for age is acute on chronic. Is acute on chronic. Okay. Low weight for age is acute on chronic. Okay. Right. Then it's not that tough. Okay. Going for the next one. Waiting for your answer. So neonatology. Let's have a rapid fatafat revision. Very preterm. What do you mean by very preterm? So I am waiting for your answer. Siva, Duggu. Okay. NASA, Shreya. Waiting for your answer. What is an extreme preterm neonate? An extreme preterm neonate is less than 28 weeks of gestation age. Less than 28 weeks. Very preterm is 28 weeks to 32 weeks. Moderate is 32 to 34 weeks. Late preterm is 34 weeks to 36 to 37 weeks. Term you all know 37 to 42. Post term you all know 42 weeks and above. Low birth weight, the answer is easy, less than 2500 grams. Very low birth weight, less than 1500 grams, and extremely low birth weight is less than 1000 grams. Perinatal mortality, the definition changed to what? Is not 28 weeks, it is 22 weeks to 7 days after birth. That's it. 22 weeks to 7 days after birth. This is often getting repeated. That's why I'm thinking of repeating it again. Okay, right. So it will be easy for you to remember post term, term, everything. But with respect to very preterm and moderate preterm, it will be of somewhat difficult one. So that's why it is posted here. Might be easy for you to write. Okay, what is the feature of preterm and term? So for a pinna is elastic in preterm. Pinna is so much of elastic recoil. Breast bud will be less than 5 millimeter. Hair will be of lanugo silky hair. Sole creases up to anterior one third transverse crease. Anterior one third of sole in preterm. Male external genitalia is undescended or it can be in the root of scrotum. Female external genia minora will be visible. Complications, let me tell you. Whereas post-term pinna will be firm, breastbed will be more than 5 mm, hair normal silky hair instead of fragile, sole creases full sole. Sole creases full sole. Male external genitalia, descended testis, black rugal scrotum. Black and rugal scrotum. Scrotum. Female external genitalia, minora will not be visible. Minora will not be visible. Visible. So what are all the complications? So what are all the complications? So complications in preterm. Let me tell you what are all the complications in preterm. Almost all complications will come. One is necrotizing enterocolitis. They can go for intraventricular hemorrhage. They can go for patent ductus arteriosus. They can go for retinopathy of prematurity. They can go for sepsis. They can go for hypoglycemia. They can go for hypothermia. These are all the things common in preterm. Common in preterm. Whereas in term, particularly with respect to a small for gestational age. Small for gestational age means 10th centile. Gestational age means 10th centile. Okay. What are all the complications? They will have asphyxia, intrauterine asphyxia. They are prone for birth asphyxia. They are prone for meconium aspiration syndrome. They are prone for hypoglycemia. And finally, they are prone for polycythemia. So this is how we differentiate between a term SGA and a preterm appropriate for gestational age. Okay, very important. So they might be asking you the following are common complications of preterm except. The two things that it get confused is one is meconium aspiration syndrome, another is polycythemia. Okay, right. Over. So what is this scoring system called as? What is this scoring system called as, and what for it is utilized? Tell me. What for it is utilized? Tell me. Siva, Duggu, Shreya, NASA, what is this and what is the utilization of this chart? What is this chart? Yes, answer please. What is this chart? What is this chart? In case of newborn, very easy to find out dash. So this is called as, shall I wait or you will answer? You are the go, NASA, shall I wait? What is this chart? So this is called modified Ballard scoring. Modified Ballard scoring. To find out the age of preterm. Age of preterm. In this you will get 6 neurological criteria, 6 physical criteria. So totally 12. To find out the gestational age of the baby. To find out the gestational age of the baby, and it can be valid up to 1 week after birth. After that it is not valid. 1 week after birth, after that it is not valid. Okay, after that it is not valid. Okay, right. So this is called Ballard score. Very, 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 very important thing is Ballard score minimum is -10, which corresponds to 20 weeks. Which corresponds to 20 weeks. Maximum is 50 score, which corresponds to 44 weeks. So it is -10 to +50. The score is 20 weeks to 44 weeks. -10 to +50 correspond to 20 weeks to 44 weeks. Right? Okay. So what is this? What is this? Waiting for your answer. What is this? So you can get keratin plaques in the gingiva. This is called bone nodules. This is called as what? Bone nodules. And what is this? Keratin filled plaques in the hot palate. This is called Epstein's pearls. This is called Epstein's pearls. So the first one is keratin filled plaques in the gingiva. The second one is keratin plug in the, what is that? Hot palate. Okay, right. So what is this? Again, what is this? Important spotters. What is this? Red macular rashes. So this is called again benign. This is erythema toxicum. This is erythema toxicum. One second, please. சொல்லுங்க மேடம். குட் ஆஃப்டர்நூன் மேடம். ம், சரி மேடம். சரி மேடம். ஆ, சரி மேடம். நாளைக்கு அனுப்பு. நம்ம எல்லாம் இல்லை மேடம், எல்லாமே ஃப்ரீயா. சரி மேடம். பெட்டு பண்ணிடலாம் மேடம். ம், வில் டேக் கேர் மேடம். ம், நேம் அந்த பிஜிஸ் எப்போ மேடம் ட்ரான்ஸ்ஃபர் பண்ணுறது? ஓகே மேடம், ட்ரான்ஸ்ஃபர் பண்ணி ஓபிக்கு அனுப்ப. வில் டேக். நாங்கள் வில் பி இன் ஓபி ஃப்ரம் 7:45. OP time ends by 10. Okay, madam. Sure, madam. Name, madam. Patient name, madam. Urtisha. Okay, madam. Okay, madam. Okay, what is this? So, in the meantime, you should start answering now. So, what is this? First one is erythema toxicum, red macular plaques. So, what is this? This is called sucking blisters. This is called sucking. Normal. All these things are normal. Whether you treat or not, it will go. Whether you treat it or not, it will go. Whereas the one on this, can you tell me the child is toxic? What is the answer for this one? You tell me what is the answer for this one? The second image. What is the answer? What is the answer for this one? Anyone? This is scleroderma. This is what? Scleroderma. What is scleroderma? Scleroderma is what is that? Wood-like induration. Wood-like induration of subcutaneous fat. Induration of subcutaneous fat occurs in gram-negative sepsis. Occurs in gram-negative sepsis, and invariably majority of them will die. So this is a question. Scleroderma, very very important. This is scleroderma. Okay, so remember your bone nodules, your Epstein's pearls, your erythema toxicum, your sucking blisters, they are all normal. Whether you treat it or not, the child is going to be fine. But this woody induration of the subcutaneous tissue is called scleroderma, occurs in gram-negative sepsis due to the oxidation of the subcutaneous fat, and majority of them will die. So scleroderma is a grave prognosis, right? Okay, so what is this? Less than 28 weeks, what do you feed? 28 to 31 weeks, how do you feed? 32 to 34 weeks, how do you feed? And less than 34 weeks, how do you feed? Come on, fatafat answer in a single post. Less than 28 weeks, the child is not suitable for enteral feeds. So, total parenteral nutrition. 28 to 31 weeks, the child doesn't have sucking or swallowing, but intestine wants to get mature. So, nasogastric feeding. Nasogastric feeding. Third one, 32 to 34 weeks. Everything, sucking is there, swallowing is there, but sucking, swallowing coordination is not there. So, you need to give what? Dash. Very simple. What is that? You need to give what? Dash. What is that? Paladai feeding or Gokarnam feeding. Paladai. And finally, more than 34 weeks, sucking, swallowing coordination is established. So that you need to give what? Direct breastfeed. You need to give what? Direct breastfeeding. Right? This is for preterm nutrition. Okay. Is it okay? So, shall I go for the next one? Thermoregulation. Temperature or thermoregulation. So, yes, start. What is the ideal delivery room temperature? The answer is 1, 2, 3, 4, 5. 25 degrees Celsius. What is the normal newborn temperature? 36.5 to 37.5. Mild hypothermia means 36 to 36.5. Moderate hypothermia means 32 to 36. Severe hypothermia means less than 32 degrees Celsius. Hyperthermia means more than 37.5 degrees Celsius. Usually, the manifestation of bacterial infection is fever. But in newborn, the manifestation of bacterial infection is hypothermia. Only very few conditions that can produce hyperthermia in newborn are herpes and malaria. You all know that hypothermia can occur as a result of because of contact with the surrounding table, conduction, without contact, radiation, due to airflow, convection, and finally heat loss through skin is evaporation. Heat loss through skin is evaporation, right? Okay. Right, so this is with respect to temperature regulation. Definitely you will get a question from this. Okay, right. So what are all the possible questions that can be asked? The possible question that can be asked is this one. Mild hypothermia means 36 to 37, 6.5 degrees Celsius. Kangaroo mother care can be started with when the child achieved 1800 grams. Okay, right. So then resuscitation, neonatal resuscitation. Are you all ready? Neonatal resuscitation. Right. So whenever any child doesn't cry immediately after birth, the child will go for primary apnea followed by secondary apnea. What do you mean by primary apnea? The heart rate is reduced but not the BP. So bradycardia without hypotension. Whereas secondary apnea means you will get bradycardia and the child's heart is not able to maintain BP, so it is with hypotension. In primary apnea, when you give tactile stimulation, the child will cry. Tactile stimulation. But in secondary apnea, you can't do this tactile stimulation, and invariably you need to go for bag and mask ventilation. You go for bag and mask ventilation. Okay, then okay. So whenever any child is born, what are all the first assessment? 3 points. You don't see cyanosis, you don't see Apgar, but you see what? What are all the initial assessment that you see? The initial assessment you see is whether it is a term or preterm. Tone is how much? Tone is how about hypotonia, normal tonia, and whether the baby has established crying or breathing. That's all. Only three. Color will not be taken into account. Cyanosis will not be taken into account. Okay. Second one is Apgar is not taken into account because Apgar usually start by 1 minute, 5 minutes, 7 minutes, etc. But neonatal resuscitation is started immediately after birth. So you cannot wait for an Apgar score to put at the end of 1 minute. Because at the end of 1 minute, you need to immediately start bag and mask ventilation or positive pressure ventilation. Okay, right. Okay, what do you mean by sniffing question? This is extended neck. That means your nasopharynx, trachea and oropharynx in the straight line. So that what you need to do, keep a roll of towel under the shoulder blade. That is called sniffing position in the initial steps of resuscitation. Very good. Heart rate, Siva, no, my dear, heart rate will not come under the initial preliminary resuscitation. As heart rate is mainly counted for after resuscitation because increase in the heart rate indicates that your resuscitation is going on a proper way. Suction of mouth followed by suction of nose. There is at present there is current guidelines did not support tracheal suctioning. Instead, you can directly start bag and mask ventilation. Again, bag and mask ventilation is not a contraindication even in meconium aspiration at present. The only contraindication is diaphragmatic hernia. When the child breathing heart rate is more than 100, but the child has got labored breathing or cyanosis, what will you do? CPAP. The answer is what? CPAP. Okay, only when the heart rate is dropped that you need to go for your neonatal resuscitation. Otherwise, labored breathing or cyanosis, you can do CPAP. Right. Next, very, very important. Primary apnea, secondary apnea. Next, cot clamping. You all know that. Cord clamping has been incorporated in the current guidelines and it is 30 seconds to 60 seconds after birth. What do you mean by golden time? You need to start resuscitation within 60 seconds after birth. As we discussed already, response to resuscitation is increase in heart rate. If heart rate is more than 100, withdraw your bag and mask. If your heart rate is 60 to 100 per minute, continue bag and mask. That is positive pressure ventilation. If the heart rate is less than 60 per minute, along with positive pressure ventilation, you need to give 2-thumb cardiac massage. It is not 2-finger cardiac massage, and it is what 120 events, 90 chest compressions with one ventilation. That is 1-1-1-2, 1-1-1-2, 3:1 ratio. When the heart rate is 60 to 100 per minute but not increasing with PPV, what you will consider? Waiting for my kids to answer. Shiva, Dugu, Nikku, Ram. Yes. When the heart rate is 60 to 100 per minute but not increasing with positive pressure ventilation, what is that? Anyone? What will you do? Waiting for your answer. Waiting for your answer. No, Dugu, no. The child heart rate is more than 60. What is the indication for adrenaline, my dear child? Heart rate is less than 60, start cardiopulmonary resuscitation. Even if after 1 minute of successful CPR, if the child heart rate doesn't increase, then you need to give for adrenaline. Here the heart rate is just 60 to 100 per minute, but not increasing with PPV. That is called what? Mr. SOPA. What is Mr. SOPA? M stands for properly position the mask. R stands for reposition the neck. S stands for suctioning of mouth and nose. And O stands for open the mouth. P stands for put adequate pressure of the on the what back, and A stands for if nothing goes well, then either you need to intubate the child and doing bag and tube ventilation, or you can put laryngeal mask airway, right? If nothing goes well, at the end of 60 seconds of CPR, if the heart rate is not increasing, then you give adrenaline. What are all the drugs that we use? Adrenaline, we use normal saline bolus, you use O negative blood, we don't use RL. I repeat, we don't use RL. Okay, because the child in birth asphyxia will have an underlying lactic acidosis. When you still add RL, which contains lactate, the amount of lactate will be injurious to the treating child. That's it. Okay, right. This is again very, very important. You all know that what is the treatment for preterm. Again, people will be realizing that whenever I come across a case of preterm with the island membrane disease, what should I do? People will be invariably voting for surfactant. The answer is wrong. For any case of preterm with respiratory distress, you need to start CPAP. Majority of the time CPAP will be the winner. Okay, so you start CPAP doesn't mean that you need to go for a insure. When CPAP doesn't work, you need to go for intubate, surfactant administration and extubate. When insure fails, then you need to go for mechanical ventilation. But majority of the time, majority of preterm babies will come up with the CPAP. Okay, right. CPAP, right. Heart rate assessment, initially it was palpation of umbilical cord, then it changed to stethoscope, now it is electronic monitoring. Okay, as we already discussed, it is 90:30, that is 3:1, 3 chest compression, 1 ventilation. Level 1, what do you mean by level 1, level 2, level 3 NICU care? Level 1 is a normal stable child of more than 2500 grams, whereas between 32 to 40 weeks and more than 1500 but less than 2500 grams, level 2, whereas less than 32 weeks and less than 1500 grams, it is level 3. Okay, you need to keep the child in that levels. What is called newborn stabilization unit and what is called SNC? Again, beautiful community related questions was asked in INI-CET as well as in NEET. Newborn stabilization unit is sick newborn but above 1800 grams, whereas SNCU means less than 8800 grams. SNCU has been tremendously working well in across many states of India. Okay, right. So this is important. Okay. So what is this? Let me wait for your answer. What is this? What is this? What is this, my dear boys and girls? Come on, answer. Are you sleeping because of your lunch time? So what is this? So what is this? This is capot over the presenting part. This is cephalohematoma. So what is the difference between cephalohematoma, capot as well as subgaleal bleed? The answer is very simple. When it is in the subcutaneous plane, present at birth, crossing the sutural borders and resolving within a week, it is caput succedaneum. Whereas it is not present at birth but delayed by about a day or two, and it takes such a long time, it may go for an abscess, it can go for an hyperbilirubinemia, or it can, okay, but it doesn't cross suture line, usually due to forceps delivery causing parietal bone fracture, cephalometoma. And finally, when you have a periorbital puffiness, when you have a periorbital puffiness and periauricular puffiness, and the child is in profound shock, it is subgaleal bleed. You need to give a trial of vitamin K and FFP. Okay. For this subgaleal bleed, often they are brought with shock, unlike the children with this one. What is that? Caput and cephalometoma. Right? Okay. Caput, and so fill this abgar. Let me give you time. Fill this abgar. Fill this abgar. What is the reason? So difficult or easy? Fill this abgar. So abgar scoring is not that tough, my dear boys and girls. So 0, 1, 2. What do you mean by that? So pulse appearance. What do you mean by appearance? The child is pink. Heart rate more than 100 per minute. With NG tube, the child is smiling or pulling the tube. Pulling the tube. Activity, flexed posture of both upper and lower limb. Respiration, crying. So 0. So on the other hand, if the appearance is blue tongue, central cyanosis, I'm sorry, reverse I am doing, 1 second, reverse I am, so let me say 210. Let me say 210. So blue tongue, pulse, no pulse. Okay, the child is not reacting to NG tube in the nose. Activity, floppy, uptended. Respiration, gasping or no, is 0. So 2 is this, 0 is this. In between this, you have 1. Okay, so Apgar score, mild, moderate, severe, you can have. Okay, remember Apgar score does not reflect HIE. I repeat, Apgar score does not reflect HAE, but it reflects as prognosis, whether the child will be surviving or not. Okay, right. What is this Downey score? So this is Downey score. What is this Downey score? There are 5 criteria. Respiratory rate less than 60 per minute. Cyanosis. Okay, retractions. Okay, respiration is okay. Less than 60 per minute. Cyanosis. What do you mean by cyanosis? I'm sorry. Abgar and little bit of confusion. So when the respiratory rate, I repeat, so less than 60 per minute, the child is doing fine. 60 to 80 per minute, moderate mild respiratory distress. More than 80, severe respiratory distress. Cyanosis, no cyanosis is given a score of 0. And what about one particularly cyanosis requiring less than 50% oxygen? Cyanosis require more than 40% of oxygen. So retractions, no retractions, mild retractions in 1 and a score of moderate to severe retractions in case of 2. Grunting, no grunting in case of 0, whereas grunting with the stethoscope in case of grade 1 and grunting even without the stethoscope is grade 2. Whereas air entry is normal in 0, reduced air entry in 1 and absent air entry in 2. Absent air entry in 2. Remember, 0 to 3 is mild respiratory distress. 4 to 6 is moderate respiratory distress and 7 to 10 is severe respiratory distress. So this is all about Downey score. Definitely this will be asked. Downey score. Okay. Then. Okay, what is this? Okay, what is this? What is this? So this is laryngeal mask airway. So when will you do? So Mr. Sopa, you are doing back and mask ventilation despite correcting all this, either into alternate A for alternate, whether you need to intubate the child or you can put a laryngeal mask airway, right? Okay. So what is this answer for this X-ray? The child with respiratory distress, scaphoid abdomen. What is this? Child with respiratory distress and scaphoid abdomen. What is this? What is this? The child with respiratory distress. What is this? Unscaphoid abdomen. So the answer is easy. When you have a scaphoid abdomen, when you have a respiratory distress, and when you have intestinal lumens in the chest, it is congenital diaphragmatic hernia. Congenital diaphragmatic hernia, most common on the left side. You all know defect in pleuroperitoneal membrane. Okay, right side or central is Margagnia. Right side or central is Margagnia. Central is Margagnia. Okay, right. Okay, so laryngeal mask airway is a spotter, congenital diaphragmatic hernia is a spotter. Okay, then comes, when will you say hypoglycemia? When will you say a blood glucose of less than 45 milligram per deciliter in the newborn is called as hypoglycemia? What are all the patients can go for hypoglycemia? Less than third centile, more than 90th centile and go for hypoglycemia. Gestation less than what? Gestation less than dash weeks are prone for hypoglycemia, 36, 37 weeks. And a birth weight of less than 2000 grams are prone for hypoglycemia. What is the treatment for Asymptomatic. Asymptomatic means blood glucose 20 to 45, but the child is plain. Then continue breastfeeding. Whereas symptomatic child means what? Child is showing some kind of distress or a drowsiness, etc. In those symptomatic child, you need to give 2 ml per kg of 10D, 2 ml per kg of 10D. What do you mean by resistant hypoglycemia? This is very, very important. Resistant hypoglycemia is very, very important. So, more than 1 week of sugar requirement. More than 1 week of dextrose infusion requirement. Then you need to think of resistant hypoglycemia. Okay, what is the treatment for hypoglycemia? Treatment for hypoglycemia is 2 ml per kg of 10D. Okay, this is all about hypoglycemia. What is this? Polycythemia in newborn. What is this? Have water and cup. Another important aspect is polycythemia. So, what is define polycythemia in newborn? Waiting for your answer. Define polycythemia in newborn. What is that? Whenever your hematocrit is more than what? Whenever your hematocrit is more than 65%. Hematocrit is more than 65%. It is called polycythemia. But you are just measuring. This is an indirect measurement. True thing is, with the help of viscosity, should be measured with the help of viscometer. That is called Brooksfield viscometer. Brooksfield viscometer. Okay. What are all the symptoms? You can get dizziness because of brain gets clogged now. One. You can get low vision. You can get respiratory distress syndrome. You can get priapism. You can get necrotizing enterocolon. Okay. Causes most often present in SGA, twin to twin transfuse. Okay. Yes, seizures. What is the treatment for a symptomatic polycythemia? Partial exchange transfusion. That means you give 20 ml of normal saline, and you give 20 ml of normal saline, and you give 10. You take 10 ml of 10 ml of blood. So this is called partial exchange transfusion. Okay. When you I'm a little bit sorry, you give 10 ml of normal saline, but you take 20 ml of blood. That is called as partial exchange transfusion. So when the child, when asymptomatic, when it is 65 to 70%, observe. When it is 70 to 75% hydration, that is IV fluid. When it is more than 75%, even when asymptomatic, you need to go for PET. Even when asymptomatic, you need to go for partial exchange transfusion. So partial exchange is giving 10 ml but taking 20 ml. Giving 10 ml but taking 20 ml is partial exchange transfusion. Okay. And what is this hemorrhagic disease of newborn is all vitamin K deficiency status. Early onset is usually classical 2 to 6 days after birth because of not giving vitamin K at birth. Okay, I'm sorry, which one is classic? Classic. Whereas early onset within day one, within 1 day. Due to maternal anticonvulsants. Due to maternal anticonvulsants. Okay, late onset is more than 7 days after birth. In all cases of late onset sepsis, you need to rule out neonatal cholestasis. But one cause is cystic fibrosis. Okay, prophylaxis, yes, all less than 1 kg should be receiving 0.5 milligram of vitamin K, whereas more than 1 kg you need to give 1 milligram of vitamin K IM. Okay, what is the best test? It is not PT, it is not APTT, it is protein induced in vitamin K absent. It is protein induced in vitamin K absent. That is called PUCA. Okay, protein induced in vitamin K. That is called PUCA. Right? Okay, come on, go through. What is this? What is this? Answer. Breastfeeding. Breastfeeding jaundice. What is the correct term? Breastfeeding jaundice. What is the correct term right now? Waiting for your answer. Breastfeeding jaundice. What is the correct term? Siva, Ram, Shreya, Tony, Dugu. What is the correct term for breastfeeding jaundice? Breastfeeding jaundice is due to low breast milk, as a result of which increased enterohepatic circulation, as a result of which you will get jaundice. But that new terminology has been taken. Very good, Shiva. Very good. It is called suboptimal intake hyperbilirubinemia. It is suboptimal intake hyperbilirubinemia. Very good. Whereas breast milk jaundice is due to the presence of pregnanidiol in the breast milk, and you need to consider when your serum bilirubin is more than 10 milligram per deciliter for more than 3 to 4 weeks, you consider breast milk jaundice. Okay. Apart from breast milk jaundice, what are all the other things you will consider when your jaundice is prolonged for more than 2 weeks? Jaundice is prolonged for more than 2 weeks. What will you consider? What will you consider? So it can be hypothyroidism, it can be UTI, it can be pyloric stenosis, or it can be a concealed hemorrhage. So it can be G6PD or an underlying hemolysis. G6PD or an underlying hemolysis. Right? Okay. So what is this? Dermal staining of bilirubin progresses in cephalocaudal direction. Everyone knows it is called Kramer staging. It is called as what? Kramer staging. Right. So, very simple. Physiological jaundice usually 24 to 72 hours, never involves palms and soles, rarely goes beyond 2 weeks. Whereas pathological jaundice involves in the first week, goes more than 2 weeks, can touch more than 15 milligram per deciliter, can involve palms and soles. And remember, when you have a combination of clay colored stools and dark urine, neonatal cholestasis, you need to suspect extrahepatic biliary atresia. Okay? These are all very, very important. The difference between pathological jaundice and physiological jaundice. Phototherapy, you will give Z isomer is converted into E isomer. What is that called as? Configurational isomerization, which is of no use. But only structural isomerization is the one that is responsible for majority of reduction of bilirubin, and your photooxidation doesn't play a role. What is the indication for exchange transfusion? In a case of RH incompatibility, cord hemoglobin less than 10 grams per deciliter and your bilirubin is more than 5 milligram per deciliter per day increase. What is the indication for partial exchange transfusion? Remember, in case of fetal hydrops, with neonatal decompensation, hematocrit less than 35 or 10 grams per deciliter, you need to consider 50 ml per kg of packed RBC. So this is important. When will you give partial exchange transfusion? When will you give double volume exchange transfusion? So this is double volume exchange transfusion. This is partial exchange transfusion, right? What are all the manifestation of acute bind and chronic bind? Chronic bind bilirubin induced encephalopathy is more often asked. It can be leading to vertical gaze palsy. It can be associated with the vertical gaze palsy. One. It can be associated with the deafness. One is vertical gaze palsy. Second one is deafness. Third one is chorea. Chorea. Vertical gaze palsy, deafness, chorea. What else? Chronic bilirubin encephalopathy. Whereas acute bind usually starts with a shrill cry. Initially hypertonic, then becomes hypotonic. Acute bilirubin induced encephalopathy. Okay, right. So what is the answer for this one? What is the answer for this one? Tell me. What is the answer for this one? And what is the answer for that one? Waiting for your answers to post in the chat box of YouTube. Come on. Hmm. Yes. Okay. Here you see a coiling of NG tube. So what is that? Tracheoesophageal fistula. The next one, barium swallow reveals leaking into the trachea. So this is H-type fistula. This is H-type fistula. What is this one? This one is what? This one is type C, esophageal atresia. Esophageal atresia. Okay, right. 3 o'clock. So first one is type C, second one is H-type fistula, which is often missed. What is this? Diagnosis? Diagnosis. What is this? Gingival hyperplasia is associated with what? Waiting for your answers. So, this is typical of myelomonocytic AML. Myelomonocytic AML. Either M4 or M5. Monocytic AML. Either M4 or M5. Okay. Right. So tell me the answer. Unilateral exophthalmos, bilateral exophthalmos. I am waiting for your answer. Answer. So, what is this? Unilateral exophthalmos. This is bilateral exophthalmos. Bilateral exophthalmos and scular crustacean triad. That is What is that? HLH or LCH? It is LCH. Lympho LCH. Langerhans histiocytosis. Whereas unilateral can be neuroblastoma. Unilateral can be one is what? Neuroblastoma, particularly with respect to raccoon eyes, periorbital ecchymosis. Unilateral. Or it can be due to what? There is a peculiar variant in myeloid leukemia. What is that called as? There is a peculiar variant in myeloid leukemia. What is that called as? Otherwise known as granulocytic sarcoma. Waiting for your answer. Otherwise known as granulocytic sarcoma. What is that? Waiting for your answers. It is otherwise called granulocytic sarcoma. Peculiarly involving ovary test subcutaneous orbit. What is that AML called as? That's not that tough, dear. Otherwise, other name is myelocytic sarcoma. What is that? What is that? Tell me. Have anyone answered? What is that called as? Name given to that. What is that called as? Name given to that. Still answering. Name given to that. You need to answer. I will wait for it. Starts with what? None are have answered. This is called chloroma. What happened to you? This is called chloroma. Okay, right. So what is this? What is this? Multiple osteolytic lesions. Multiple osteolytic lesions. Tennis racket cells. You all know it is Langerhans cell histiocytosis. Langerhans cell histiocytosis. It can be a triad of Hans Color Christian triad. What is this Hans Color Christian triad? Bilateral exophthalmos, diabetes insipidus, and osteolytic skull lesions. Whereas what is this one? What is this one? Tennis racket cells in electron microscopy. Electron microscopy, and one more clue is it is CD1A positive. It is CD1A positive marker. Okay, 1A positive. Right. Okay, come on. What is this then? Most common in childhood malignancy. What is the most common childhood malignancy? Waiting for your answer. What is the most common childhood malignancy? Yes. Waiting for your answer. We don't have much time. We need to go further. Within 40 minutes, we need to finish. Most common is ALL. Second most common malignancy is brain tumor. Most common solid tumor is brain tumor. Most common extracranial neoplasm, and second most common solid tumor is neuroblastoma. Okay, most common Hodgkin's lymphoma in India is mixed cellularity. Most common non-Hodgkin is lymphoblastic lymphoma. Lymphoblastic lymphoma. Okay, right. Okay. What is the most common abdominal malignancy in infancy? What is the most common abdominal malignancy in infancy? No, it is neuroblastoma. Neuroblastoma, most common abdominal malignancy. Most tumor of kidney is Wilms. Most common leukemia in Down syndrome is ALL, whereas most common leukemia in Downs less than 3 years is megakaryocytic AML, M7 megakaryocytic. Most common infant leukemia is 411 translocation, MIL gene. What is that called as? MIL gene, 411 translocation. Most common congenital leukemia is usually acute myeloid leukemia. So these all commonest things will be asked. Okay, right, very good, very good, very good, right. Now, we are not treating all cases as such. It all depends on whether he belongs to standard risk or low risk. Standard or low risk means they will start treatment. High risk means either they will start more toxic chemotherapy drug or they will say palliative therapy. So age 1 to 9 years is standard. Female sex is standard. WBC count less than 50,000 is standard. Absence of hepatosplenomegaly is standard. Absence of CNS and mediastinal is standard. Phenotype, okay, phenotype usually, okay, B cell, mature, better type, ploidy, hyperdiploidy has good prognosis. Okay, cytogenetics, what? Philadelphia has got bad prognosis. Apart from the trisomy 10, trisomy 8 has got good prognosis. What is the response to treatment? Within 7 days of prednisolone, no blast in smear. What do you mean by minimal residual disease? It means identification of 0.01 percentage of cells with different cytogenetic corresponding to leukemia. So this is called minimal residual disease. You need to have special DNA probes. This is called as what? Minimal residual disease. High risk, less than 1 year, more than 9 years. All male sex, count more than 50,000 and high risk. A presence of hepatosplenomegaly, CNS involvement, high risk. Phenotype, pre-B. Pre-B comes under good prognosis, whereas B cell and T comes under bad prognosis. Cytogenetics, Philadelphia chromosome 911 worst prognosis. Response to treatment what? Response to treatment after 1 week the child is brought. Okay, right, that is high risk, right? Okay, so what is this spotter? Beautiful spotter. What is this? Beautiful spotter. What is this? That already that we had explained in detail. What is this? Waiting for your answer. Can anyone tell me what is it that just now we have discussed now? So this is called raccoon eyes. This is called raccoon eyes. So this is called raccoon eyes. In which condition? Neuroblastoma. Neuroblast. Raccoon eyes. Okay, right. So what are all the other MCQs that can be asked with the neuroblastoma? It can go for spontaneous regression like LCH. This point was discussed. It arises from neural crest, can be associated with all these syndromes. MCQ, deletion 1p, MCQ, spontaneous regression can go for. Okay, And then what is the important thing in stage 4? Yes, this is very, very important, and important MCQ and important update for you. Whenever you say a cancer on stage 4, invariably you will have a poor prognosis. But stage 4 cancer, 4A, 4S cancer in neuroblastoma has a small primary in the suprarenal gland with a small secondary in skin, small secondary in liver, and small secondary in the skin, and small secondary in the liver. This has got excellent prognosis provided if the child is less than 18 months. Okay, so again, this question will be asked: what are all the favorable and what are all the unfavorable histology? Definitely, we will be asked. You will be confused. Why stage 4S is included? Stage 4S has got good prognosis because it involves limited primary, limited two secondaries, and the child age is less than 18 months. So stage 4S will confuse you. Make sure of it. Right. What about Wilms tumor? What are all the questions can be asked? Most common tumor of the kidney. Most common is asymptomatic abdominal mass. That the triad of pain, hematuria, abdominal mass is present only in 10% of cases. It can be either sporadic or hereditary. Sporadic is unilateral. Hereditary is bilateral. Hereditary can be associated with Vagar syndrome, Dennis-Chas syndrome. Which one? Which one? Wilms tumor. So Vagar syndrome, Dennis-Chas syndrome, and then Beckwith-Wiedemann syndrome. These are all the three syndromes associated with the Wilms tumor. And remember, stage 4S is a benign and response to treatment plus. That is the MCQ in neuroblastoma. But as far as a Wilms tumor is concerned, stage 5 is not disseminated involvement. Stage 5 is opposite side kidney involvement. That's an MCQ. Stage 5 is an opposite kidney involvement. It is not distal involvement. 11P and 11P13 and 11P15. 11P13 is, what is that? Beckwith Wiedemann, and 11P15 is okay, Dennis Dash. Right. So what is the inheritance which we discussed? Asymptomatic abdominal mass. And remember the difference between neuroblastoma and Wilms tumor. Neuroblastoma and Wilms tumor is, what is that? Can anyone tell me? Apart from this, 1 second. Okay. Okay, right. So apart from that, what are all the questions that can be asked? This is very, very important. This chart is very, very important, and definitely one question will be asked based on the paraneoplastic manifestations of neuroblastoma. What are all they? So point number 1, neuroblastoma with the rapidly enlarging liver mass and secondaries. What is it? And secondaries. What is it? Rapidly, and like, can anyone syndrome? Can anyone name this syndrome? Because at least 3 times this question was asked in INI-CET. Rapidly enlarging mass neuroblastoma with large secondary is Pepper syndrome. Watery diarrhea due to increased VIP is Werner-Morrison syndrome. I am sorry, Kerner-Morrison syndrome. Secondaries in bone and the presentation is limping is Hutchinson syndrome, I think. And meiosis, partial process, and anhidrosis due to involvement of C1 sympathetic chain, Horner syndrome. When neuroblastoma is associated with Ondinsker's and Hirschsprung syndrome, it is called as neurocrystopathy syndrome. And when neuroblastoma is associated with myoclonic jerks, random eye movements, and ataxia, is called as what? Opsoclonus myoclonus. That's it. Very, very important. What is this tumor? Can anyone tell me what is this tumor? Brain tumor on top and brain tumor on bottom. Answer. Brain tumor on top and brain tumor on bottom. Tell me. Come on, tell me. Okay. So, what is this? This is a component of solid and cystic. Whenever you have a solid and cystic component, it is pilocytic astrocytoma. And what is this? This is called pontine glioma. Whenever you have ataxia and multiple cranial nerve palsy, whenever you have ataxia and multiple cranial nerve palsy. Ataxia, it is pontine glioma. Unless otherwise proved, it has got poor or worst prognosis. Worst prognosis. What is this? Look at this. You have drop metastasis. Drop metastasis is suggestive of medulloblastoma. In India, medulloblastoma is more common than pilocytic astrocytoma. Medulloblastoma is usually midline cerebellum vermis, whereas lateral cerebellum is involved in pilocytic astrocytoma. Lateral cerebellum. Okay, then come on. So, is it possible to answer within a minute about this? Bleeding disorder at a glance. Anyone? Bleeding disorder at a glance. So, what is this? Come on, answer each and everything. எங்க இருக்கீங்க? ம், சரி சரி. இங்க கிளினிக்ல கார் மேடம் வரும்போது ஒரு So, what is this? So, can you answer this as a rapid fire round? Whenever you have a predominant mucosal bleeding, it is von Willebrand disease. Mucocutaneous is ITP. Mucosal and joint bleed is clotting factor deficiency. First step is look for CBC and smear study. It is not BT, CBC and smear study. There is no role for bleeding time. If bleeding time is prolonged with the normal platelet count, it is von Willebrand disease. Okay, von Willebrand disease. Right? Prothrombin time, if increased, either it is vitamin K deficiency or liver failure. Okay. Partial thromboplastin time increased means it is either factor 8, factor 9, factor 11, factor 12 deficiency, but in factor 12 no bleeding. Okay. Mixing studies, normal means clotting factor deficiency. Even after mixing, if the child continued to bleed means it is due to presence of inhibitors. Okay. Thrombin time increased means fibrinogen is low. Decreased means fibrinogen is okay. PT high, whereas but your platelet is normal. What does it indicate? What does it indicate? Again, it is liver failure. Liver failure. Okay, what is this? PT, APTT, TT high, whereas platelet is low. What does it indicate? Whereas platelet is low, what does it indicate? DIC. Whereas your PT, APTT, TT, see everything is normal, but the child is bleeding means factor 13 deficiency, curvy, hereditary hemorrhagic T-line ectasia, and finally you have child abuse. You have child abuse. Okay, it is child abuse. Okay, right. So this one chart will be more enough to identify almost many diseases. Very, very easy. Okay, right. What is that? I'm not going much deep into it. Remember, iron deficiency anemia is more common between 6 months to 6 years and more than 12 years. 6 to 12 years, rule out blood loss because it is uncommon in that age group. Okay, facial and palmar plantar means what does it indicate? Hemoglobin is less than what? 10 grams per deciliter. But if the palmar creases are also involved means less than 7 grams per deciliter. So palmar creases involved means less than 7 grams per deciliter. Some pallor means less than 10 grams per deciliter. What is the earliest feature of iron deficiency anemia? Fatigueness. Association. Remember, iron deficiency anemia is associated with the pica, associated with the febrile fits, associated with the pica, associated with the febrile fits, associated with the breath holding spells. Associated with the breath holding spell. Very, very important. So these three things apart from anemia is common with iron deficiency anemia. Pica, okay, breath holding spells, febrile fits. Okay, smear usually microcytic hypochromic. MCV will be less than 70 femtoliter, whereas RDW more than 15. Okay, what is the first response in the first day itself? Increase in sense of well-being. Increase in sense of well-being is the first response. Sense of well-being, iron binding capacity will increase. Okay, treatment right now is ferrous sulfate. The first response to treatment is increase in interest in surroundings and interest in surrounding. Okay, so the next day you will get reticulocytosis. Hemoglobin will start increase from third or fourth day, and normal hemoglobin will be achieved by 3 to normal hemoglobin will be achieved by 30 days, whereas 1 to 3 months for ferritin, 1 to 3 months for ferritin to become normalized. What is called IRIDA, iron resistant iron deficiency anemia? Usually in India it is due to celiac disease. Whenever you see a microcytic hypochromic anemia and not responding to iron treatment, kindly rule out celiac disease. Very, very important question for you. Very, very important question. And B12 and folate we had discussed. Folate not eating, what is that? Okay, so folate deficiency is usually not eating green leaf vegetables, and when you are on phenytoin, you can get. Okay, B12 deficiency predominantly vegans. Investigation of choice, this is serum folate levels. Whereas investigation of choice here is methylmalonic acid in urine. Hypersegmented neutrophils is present in these two. Okay, other and but homocysteine is raised in both these things. Homocysteine is raised in both these things. What are all the clinical manifestations? So this is subacute combined degeneration of spinal cord, infantile tremor syndrome, pancytopenia are all the manifestation, as well as knuckle hyperpigmentation. Folate deficiency only macrocytic megaloblastic anemia. Okay. When you don't treat B12 and you start treating folate, paradoxical worsening can happen. Okay, right. So sometimes when you treat B12 with the B12 without giving folate, suddenly neurological symptoms will occur. This is mainly because of underlying folate deficiency. So what is the treatment? Again, this is folic acid tablets, here B12 injection. Now oral forms are also available. One such condition in which megaloblastic anemia along with the diabetes insipidus, bone marrow failure syndrome manifestation can occur in thiamine responsive megaloblastic anemia along with deafness. Very important. Okay, and what is this? When you have an anemia, rapid fire, when you have an anemia, okay, you can have either microcytic, normocytic, or macrocytic. What are all the causes for microcytic anemia? What are all the causes for microcytic anemia? So it is either iron deficiency anemia, lead poisoning, sideroblastic anemia, thalassemia intermedia, and then copper deficiency. These are all the causes for microcytic hypochromic anemia. Whereas when your MCV is high, either it can be B12 folate. When your MCV is normal, either it can be due to two things. One is hemolytic, another is non-hemolytic. Non-hemolytic anemia of chronic disease, renal failure due to erythropoietin deficiencies are common. Renal failure, erythropoietin is common. Very good. Hypothyroidism can be a cause, renal failure can be a cause. Whereas when you are, leave alone this one, whereas when you are normocytic anemia, whenever you have a normocytic anemia, then whether it is hemolysis or it can be due to blood loss. When hemolysis is there, Coombs positive or Coombs negative. Coombs positive means you can have SLE, you can have Epstein-Barr virus, etc., or you can have Evan syndrome. Whereas Coombs negative means consider either hereditary spherocytosis, hereditary elliptocytosis, sickle cell anemia, hemoglobin C and hemoglobin E disease. Okay, right. This is a simple approach. Diagnosis, spotter. So what is this spotter? So what is this spotter? Tell me, what is the spotter? The guy has pallor. The guy has pallor and the guy has red colored urine. This is true picture came to my clinic. The child is deadly pale. Look at the papery pale, deadly pale. Deadly pale. Look at this. Hemoglobinuria. Look at this. Hemoglobinuria. What's it this? This is called bite cells and this is called blister cells. Blister cells and this is called bite. What is this? Very, very easy. This is G6PD deficiency. Okay, right. So then what is this? BCG, when and where will you give? BCG, when and where will you give? BCG intradermal dose 0.1 ml route. Okay, intradermal at birth. It can be given up to 1 year. Site left deltoid. Hepatitis B. Okay, as pentavalent vaccine 6 weeks, 10 weeks, 14 weeks. Okay. So dose 0.5 ml pentavalent vaccine, route intramuscular, site anterolateral thigh. OPV is given at 6 weeks, 10 weeks, 14 weeks, at 9 months, 15 months, as well as at 5 years. Multiple boosters. Okay, fractionated IPV is given intradermal over the deltoid. It is given at 6 weeks, 14 weeks, and booster at 9 months. 9 months. Pentavalent, as I told you, 6 weeks, 10 weeks, 14 weeks. Anterolateral thigh. Rotavirus oral 6 weeks, 10 weeks, 14 weeks. Rota can be given up to 1 year, like BCG. PCV again, it is given intramuscular thigh. It is given at 6 weeks, 14 weeks, and then 9th month booster. And then 9th month booster. So this is all about vaccines. Okay, MR vaccine is given at when? MR vaccine is given at 9th month and then 15th month subcutaneous. MR vaccine is given subcutaneous. JE1 subcutaneous 9th month 15 to 18 months. Okay, DPT had been discussed, OPV discussed, JE discussed. DPT2 booster at 5 years. At 10 years, TD vaccine. At 10 years, TD vaccine. This is 10 years TD vaccine. Right? So this is again finished. So at birth, OPV, BCG, hepatitis B. At 6 weeks, 10 weeks, 14 weeks, OPV, pentavalent, rota, all are given. Whereas at 6 and 14 weeks, IPV, PCV, IPV, PC. Okay. At 9 months, OPV, vitamin A, usually I don't say, vitamin A, and then MR1, PCV booster, IPV booster, and then JE1. Whereas 16 to 24 months. Again, what DPT booster, JE second dose, MR second dose. 5 years, you give DPT. 10 years, you give TD. 16 years, you give TD. In some places, 10 to 14 years, they have included 2 doses of HPV vaccine at 6 months apart. At 6 months apart. Okay, right. Some inborn errors of metabolism. Galactosemia is one such common, often asked question. So it can present with acute hepatic failure. One other is thyroxinemia. The clue for this one, galactosemia, is non-glucose reducing substances in urine. Whereas for clue for tyrosinemia induced liver damage is increased alpha fetoprotein. Both galactosemia and tyrosinemia will cause proximal renal tubular acidosis. Acidosis. Is there any hematologic cause or neurologic cause? Neurology, it causes what? Mental retardation. It can also cause oil drop cataract. In eye, it causes oil drop cataract. Sepsis is usually due to E. coli sepsis. Dipstick will be positive, but dipstick will be negative, Benedicts will be positive, because Benedicts for glucose, fructose, lactose or galactose, whereas a dipstick only for glucose. That's why in galactosemia, Benedicts will be positive, dipstick will be negative. Dipstick will be negative. Okay. Right. Then breastfeeding is absolutely contraindicated. Breastfeeding is absolutely contraindicated. Okay. Then diet advice. You can't give galactose or breast milk. What is GALT deficiency? Okay, so GALT deficiency, galactokinase deficiency in galactose uridyl transferase, the manifestation is acute hepatic failure, neurological insult, microcephaly, etc. apart from cataract. Whereas in galactokinase deficiency, it is only cataract. It is only cataract. Remember, non-glucose reducing substances in urine. Okay. So this all you know. Sweaty fet urine, isovaleric acidemia. Where do you get this swimming pool? Tomcat's urine, maple syrup urine, burnt sugar. Tomcat's urine. What is that tomcat's urine? Multiple carboxylase deficiency. Sulfurous urine, homocystinuria. Boiled cabbage, tyrosinemia. Mousy or musty odor, phenylketonuria. So tell me, where will you get swimming pool and hops like urine? Waiting for your answer. So you fill up the blanks. I'll be waiting for you. You need to answer. I am waiting for you to post. Yes. Answer. Have you answered? No one? Why? I am waiting for your answer. What is this? Hops like is Hofskinuria. What is that swimming pool odor? Swimming pool odor? What is that swimming pool odor stands for? You are going to answer. So I'll give homework. You search and tell me what is this. Okay, right. Again, and very important. Is it possible to identify, or is it possible to differentiate mucopolysaccharidosis? The answer is definitely yes. For Hurler syndrome, mental deficiency will be there, coarse facial will be there, corneal clouding will be there, visceral megaly will be there, short stature will be there, all will be there. Whereas in she is milder variant of Hurler's. Whereas in Hunter, Corneal clouding will not be there, others plus or minus. San Filippo is very, very important. In San Filippo, the only issue is mental deficiency. So they will be absolutely normal but without any other features. So they will be a good looking mental retard. So other things will be plus or minus. Other things will be plus or minus. Okay, other things will be plus or minus. Whereas in 4 is what? Marque. 6 is what? Marotier Lamy. What is the difference between these two? These two do not have much of mental deficiency, coarse facies, corneal clouding. Both of them are characterized by dysostosis multiplex. Predominant involvement is skeletal. Then what is the difference between these two? Visceromegaly will be there in Marotier Lamy. Visceromegaly will not be there in Marque's. And Marque's is characterized by protruded sternum and short stature compared to Marotier Lamy. Okay, that, and remember, just like your Down syndrome, your Marque's and Marotier should undergo cervical fixation because they are more prone for atlantoaxial dislocation. They are more prone for what? Atlantoaxial dislocation. Which one? Marque's and Marotier. So a simple revision. Hurler syndrome contains everything: coarse facial features, mental retardation, corneal opacity, visceromegaly, and then skeletal dysplasia. Whereas she is a milder variant. Hunter doesn't involve cornea. San Filippo only involvement is mental retardation. Marque and Marotti doesn't have mental retardation, corneal coding, coarse facial features. But both of them are characterized by severe skeletal dysplasia. Whereas you will get visceromegaly in Marotti Lamy, no visceromegaly in Marque's. That's it. That's it. Okay. Based on this, you will get a question I swear. Okay. And what is this? What is this? Thiamine, IEM treatment at a glance. Thiamine is used in maple syrup urine disease. Riboflavin is used in mitochondrial disease. Biotin is used in multiple carboxylase deficiency. Pyridoxine is used in homocystinuria. B12 is used in methylmalonic aciduria. Whereas sodium benzoate, sodium phenyl acetate, arginine are used in urea cycle disorders. L-carnitine are again in organic acidurias as well as mitochondrial disorders. Metronidazole, organic acidurias. Nitisinone, tyrosinemia. I don't have much time to explain. Nitisinone, tyrosinemia and alkaptonuria. Miglustat, substrate reduction therapy in Gotcher. Lorenzo oil, X-linked adrenoleukodystrophy. X-linked adrenoleukodystrophy. Right? That's it. This one particular slide, I bet, will fetch you 2 MCQs. I bet, because it contains everything. Right? And I'm not going to discuss milestones in detail. So what is this? What is this? What is this? So ventral suspension. The child's head is below the level of spine. That means less than 12 weeks. By 12 weeks, very good. Okay, very good. By 12 weeks. So what is this? What is this? Pelvis above the level of the ground, and the child starts kneeling with flexed hip and flexed knee. In which age? So this is 6 weeks. By about 2 weeks, flat pelvis, extended hip, extended neck. By about 6 weeks, flexed neck, flexed hip, so that pelvis will be high. Look at this. What is the age of this child? Simple. Neck and spine are in line with each other. So it is 12 weeks child. That's it. So look at this. What is this? What is this? What is this? So the child is absolutely sleeping 2 weeks. What is this? Chin 45-degree up. Chin 45-degree up. Which age? Very, very important MCQ, 8 weeks. Chin 45-degree up, 8 weeks. What is this? Chin up, chest up, flexed elbow, 3 months. Is what? 3 months. Again, chin up, chest up, flexed elbow, 3 months. Whereas child extended elbow, 6 months. 6 months. Okay. Again, what is this? Child is able to sit but with support. This is called as what? Tripod. This is what is called tripod. 6 months. What is called tripod? 6 months. So what is this? Sitting without support. Without support. What is this? 8 months. And again, the most beautiful things, turning diagonally back, turning diagonally back, pivot, turning diagonally back, pivot, 9 months. Towards the source of sound, 9 months. Okay, this you revise. And what is this? Usually, okay, this is often a forgotten one. Okay, by about 1 year, the child will have developed these things, begins to count, name 1 to 2 color. Okay, simple rhymes by about 2 years. Left right discrimination by about 4 years. Okay, by about, I am sorry, this is for 3 years. Left right discrimination 4 years. Returned play like a doctor or nurse by about 4 years. 3-step commands, 4 digits, 4 colors by about 5 years. So with this, I am finishing my 4-hour session for today. Thanks for your patient listening. Hope you will be getting single digit ranks or at least double digit ranks. Revise this and go. Definitely you will get a good mark. Okay. Hope I'll see you soon in ICH, Institute of Child Health, MMC, if you are going to take MD Pediatrics. Bye bye. All the best. Okay. Just revise, relax yourself, sleep for about minimum 7 hours per day, because only then the next 16 to 17 hours you will find it very useful. So don't ever spare your time for sleep. Just try to spend at least 7 hours for your sleep. 1 hour afternoon nap is mandatory. Remaining 14 hours you will be brisk. So all the best for you. Bye bye.